Hello, hello, hello. Hello, my friends. Jill Osborne, IC Network. What on earth is going on with my eye? It is time for our National IC Support Group meeting. And let me just get everything set up here. All right, that's set up, that's set up, that's set up. Hi, nice to see you. Nice to see you. Let's see here. Hi, Facebook. All right, good. Hello, everybody. Jill Osborne, IC Network. I am the president and founder of the Interstitial Cystitis Network. There you go. And I do support group meetings almost every Sunday. Sometimes we do drop-in meetings too. We did a drop-in meeting this week on Facebook on Thursday morning. And my job here is to educate you, to empower you, to give you some more information. My goal here is to try to open new doors for you if you're struggling with getting better, if you've just been newly diagnosed and you're not sure what to do next. That's my job. My job here is to try to open some doors, offer some explanations. Your doctors, honestly, they just can't take the time to explain a lot of stuff like I can. And so hopefully, if you have questions, I can answer those questions and give you some context and all that sort of good stuff. So we are broadcasting live on Facebook and YouTube. If I'm looking here, I'm looking at YouTube. If I'm looking up there, I'm looking at Facebook. And it's super hot here. And so I'm going to be all sweaty. Give me 1 sec. I'll be right back. Hold on. Okay, there we go. There we go. So, what do we have in terms of IC news today? We're going to be announcing not a clinical trial. We're going to be announcing an IC research study tomorrow. It is from the University of New Mexico, and it is a study that you will be able to participate in from the comfort of your home. So hopefully you've signed up for the IC Network mailing list. If you haven't, go on over to icnetwork.org and do that. This is the first research team to develop a brand new program specifically for patients with pelvic pain and other pain conditions such as IBS, vulvodynia, etc. That's going to use some of the brand new science we have on how to calm the brain and how to calm the central nervous system. So it's very, very exciting, super, super easy. And if you have a chance to be on the ground floor and have an opportunity to participate in a brand new, very, very innovative new clinical trial. So that will be announced. I'll probably put it in a blog on our website tonight or tomorrow. And it will go out to it's already queued in our newsletter program, and it will go out to about 30,000 patients, probably around 5 a.m. tomorrow. All right. So if you want more information on that, go over to the IC Network, sign up to our mailing list, or you can email me at icnetwork@mac.com, icnetwork@mac.com. Now that we have more people here, let me just introduce myself. I am Jill Osborne. I'm the president and founder. I did too much work yesterday. My back hurts today, so I'm a little bit squirmy. I'm the longest serving IC support group leader in the United States, if not in the world at this point in time. I bring to you 3 college degrees. If you're wondering what my qualifications are, I've got a degree in chemistry, I've got a degree in pharmacology, drug development, a master's degree in psychology. The IC Network was my doctoral dissertation proposal for a PhD in psychology, which ironically I could not finish because it hurt too much to drive in a car and go to school, because that's how I was when that was happening. But the great news is that my little doctoral dissertation proposal has been rated #1 by Harvard Medical School and the University of London as the most accurate, reliable, and credible website on IC. So it's still there, icnetwork.org. It's the largest free archive of IC information in the world. On our website, you'll find lots of educational material, our Living with IC video series, our support forum if you want to go in and ask questions or read other people's questions, especially if you're, let's say, for example, you got Hunner's lesions and you're not sure what treatment to do and you're curious what other patients' experiences are. That's what you can find on our website that you're never going to be able to get online, is it just hundreds of patients sharing their personal stories. Same thing with neuromodulation, InterStim, things like that. We've got 4 message boards dedicated to that. So we've got considering neuromodulation, trying it, success stories, and failures. So you can get the full scope of those issues that are going on. If you're considering pregnancy, we have a pregnancy board over there. A lot of other patients have shared their pregnancy stories over there. So you'll just find lots of very interesting information right over there on the IC Network website. It's my baby. It's my baby. Now, the other big thing that I have to share with you is our latest magazine, the IC Optimist. Now, our magazine, we've been doing this for 19 years now. 19 years. Can you believe it? I mean, I've been a sport group leader for 28 years. But anyway, IC Network, IC Optimist is our magazine. For our members, you'll have it in your member page. Gosh, if I can get to it tonight, I will put them on your member pages tonight. Otherwise, you can, for those of you who are not members and you're not getting a copy of it through your membership, the e-version is available right now in our store under IC Optimist. The print version is not activated yet because I don't have the print. I'll have the print ones on Monday or Tuesday. But what I wanted to share with you, and of course on the back cover, couple weeks, IC Awareness Month is starting, and this is a poster that you can cut off and you can post anywhere, right? You can post this anywhere if you want to try to raise some awareness about IC. But in this magazine, there are 2 important stories that I think are worth your consideration. The first one is written by a new registered dietitian who works with IC patients. Her name is Callie Kragier. And I asked her if she would do something for me, because here's the deal. Some of you are obviously food sensitive and some of you aren't. So the ones that are food sensitive, if you've got IC subtype 1 Hunner's lesions, if you've got IC subtype 2 bladder wall driven, or if you've got IC subtype 5 central sensitization, you're food sensitive. Why? Because your bladder wall is vulnerable for one reason or another, or your nervous system is vulnerable for one reason or another. Hi, Deborah. Hi, Barbara. Hi, Jay. And then if you're IC subtype 3, pelvic floor driven, IC subtype 4, pudendal neuralgia, the odds of you being diet sensitive are much lower. You're going to be able to get away with stuff that other people might not be able to get away with. And that's where, support groups are really challenging here, because, we're putting apples, oranges, and bananas in the same meeting and in the same support group, when in fact, you're not the same. There's a lot of diversity. So there are some people who absolutely are sensitive to food, and there are others who aren't. But there are a group of patients who are super, super sensitive to food. And these are patients with advanced aggressive Hunner's lesions. And for these patients, until those lesions are treated correctly, and I was working with a patient on Friday, had Hunner's lesions. They've never been treated. She had Hunner's lesions for like 25 years. They've never been treated. The poor lady had suffered for years completely unnecessarily. Because we've got big active bleeding wounds in the bladder, these patients absolutely are going to be more food sensitive. And some of them are going to be down to eating 4 or 5 foods. So this poor woman I was working with was down to eating just very, very few foods. She only drank water. She only drank a handful of foods, and she had lost a massive amount of weight. And she was, she was diagnosed 25, 30 years ago, but she didn't know any of the new stuff. So I spent a lot of time letting her know about all the new things with IC. But fundamentally, in the end, until we can get her eating correctly, she's going to be struggling. You cannot heal. Healing requires proteins. You need a healthy balance of vitamins and minerals to have a good, healthy body and to help your body heal if it has been injured. And some of you are so food restricted that you're afraid to eat, and you have malnutrition now. I mean, it happens. And this is one reason why we wrote the big IC food list that we have on our website, that big 3-column list, 13 pages long, bladder friendly, try it, caution foods, to really show you the depth and breadth of the foods that are available, that many of which are very IC friendly, that you can try. You don't need to be afraid to eat. It's really a simple, fresh, healthy diet. What works for IC patients is the outer aisles along the walls in a supermarket. The vegetable aisle is your friend. With the exception of tomatoes, you're probably going to be able to eat the vast majority of vegetables out there. You're also going to be able to eat a lot more fruits than you realize, just not citrus. The meat aisle is your friend. The dairy aisle is your friend. What's not your friend are heavily preserved fast foods. Those are the ones that have the potential of being a little bit more irritating, as well as obviously coffees and green teas and black teas and energy drinks and Kool-Aid and things like that. Those are not going to work. Your job is to create an environment to support healing. So anyway, I asked this new dietitian that we're working with, Callie Cragier, if she would go over the essential vitamins that we are often lacking in and give us IC-friendly sources of them, and also show us the signs of vitamin deficiency. And so this is the article that she is in. This is our Meet the IC Expert series. So, for example, we all know, for example, that vitamin C, also known as ascorbic acid, is going to be the most irritating food out there. There are two acids that are dominantly irritating, ascorbic acid and citric acid. So if you're taking a multivitamin that has ascorbic acid in it, that's a mistake. The odds are you're going to flare when you take a multivitamin. It's going to hurt. Why? Because of the ascorbic acid in there. A less acidic form of vitamin C is calcium ascorbate, which is a higher pH. It's more pH neutral as compared to a super acidic vitamin C. So, but here's the deal. There's a lot of foods that have a lot of vitamin C in it that should be completely friendly to you, like broccoli or green peppers. But what are some of the early warning signs of a vitamin C deficiency? It's going to be weakness, unexplained exhaustion, decrease in appetite, irritability, muscle pain, inflammation, bleeding of your gums, and spontaneous bleeding and bruising. It takes about 3 months for the body to develop a deficiency. Okay? Now, the other vitamin that is an issue for us is B6, and we're not really quite sure why, but we certainly have years and years and years and years of patient reports that B complex, specifically B6, is irritating. B12 is normally fine. B6 is more irritating. So, a deficiency of vitamin B is frequently associated with a deficiency of other vitamins and folic acid. The symptoms include anemia, EEG abnormalities, cracks in the corners of your mouth, swollen tongue. People with mild vitamin B deficiency may not present symptoms for months or years. So you get my drift here. Our goal here with this is to really give you information on where you can find IC-friendly sources of the most important vitamins and minerals. So it's a nice article. We cover B12 should be fine, vitamin D should be fine, iron should be fine, calcium is fine. Interesting fact about calcium is that your body can only absorb 500 milligrams at a time. So it makes no sense for you to take a pill that has 2,000 milligrams of calcium in it, because your body simply can only absorb 500 at a time. You have to use timed calciums. She talks about which is the best one. Calcium citrate is absorbed better. It can be absorbed on an empty stomach, while calcium carbonate cannot. Anyway, and we talk about multivitamins and stuff like that. All right, so that's the one article in here. So for any of you who are worried about your food intake and you're just not sure if you're getting enough of the right foods, she will help that with you. You know, one of my hats that I love wearing is being a consumer advocate and a consumer alert. And although I have talked about this, I talked about this a couple of weeks ago in this meeting. Of course, we now have new research on aspartame NutraSweet and cancer. There's no doubt now that NutraSweet causes cancer. It's proven in animal studies, and significant cancer, and it's a dose response curve. The more you eat, the higher the risk of cancer, especially in children. Why? because NutraSweet is broken down into methanol. What is methanol? Wood alcohol. Hundreds, if not thousands, of people die around the globe because they drink methanol. It's highly toxic. Methanol is then broken down into formaldehyde, a known carcinogen, proven carcinogen. Right? Okay. But anyway, I don't need to rant about that today. I love wearing my consumer alert hat. Okay. But the other really, really big article in here that I hope you'll pass along to your friends is Managing Pregnancy in IC. So our writer, Stacy Shannon, has worked with quite a few other patients who are pregnant. She has had 2 children, and she goes over the key fundamental issues that an IC patient faces as they're considering pregnancy. Now, listen, IC patients have babies all the time. We make great moms. I'm not worried about your ability to be a mom, but there are some things you've got to think about. Number one is how are we going to manage symptoms if your symptoms intensify? Now, and she cites the current research with that. Generally, patients do remarkably better during pregnancy than we would have expected, but it is the 3rd trimester that can be the most challenging trimester because now we have a baby sitting on your bladder, right? So anyway, we talk about treatments and how to, what you should know about treatments if you are flaring, from traditional medications to self-help, diet, labor and delivery, what to expect during labor and delivery, post-delivery, et cetera, et cetera. So anyway, there you go. Those are the 2 big articles in our latest one. We have an article on what triggers pelvic floor spasms. Of course, I dive into the IC research. We've got 8 studies highlighted, new findings, an article on SOLA therapy, which is a infrared therapy that's being used for IC and pelvic pain. And then if you struggle with migraines, we also have a new article on migraines, which is one of the common chronic overlapping pain conditions if you happen to be an IC subtype 5. So anyway, we love doing these magazines, and it's our way of giving you something in your hands that you can read, share with others. Julie By, registered dietitian Julie Beyer, shares an article on IC-friendly summer salads. And then we also have an article on loneliness, which God knows, with COVID, we're all struggling with because we've all been home for so long. And we're going to be home again for a significant period of time with the Delta variant. So hopefully this is a magazine that will give you a little bit of comfort, a little bit of encouragement, some ideas that you can talk with your doctors about, et cetera, et cetera. Always happy when one of these comes out. Our next one's going to come out in October, and we're already working on it. I already have some articles for it ready to go. Yeah, baby. Oh, it's been a busy year. Of course, the other thing everybody needs to remember is the other huge project was the release of our book, IC 101. It's not just a bladder disease. So if you're a newly diagnosed patient looking for information on what could be causing your symptoms, because in many cases it's not the bladder, it's something next to the bladder or influencing the bladder that can be the source. So again, I was thinking about this woman I was working with on Friday. So she was in her 70s, diagnosed in her 40s, first symptoms in her 20s. And, whenever I'm working with patients doing some coaching with them, we always try to go back to the beginning, because in her brain, she kept saying, but it's IC, it's IC, it's IC. And I was like, well, but what does IC mean? We know now that there's a lot of diversity in our patient population. For some of you, yeah, it's your bladder wall. You could have Hunter's lesions. For others, it's your pelvic floor. You may have had a pelvic floor injury. And some of you, inheritance matters and or abuse could be playing a role in these symptoms. So in her case, what was so interesting is that her symptoms began after she fell off a horse. She had a really bad fall off of a horse. Now, we've all shared the story of one of our Facebook members who also had been diagnosed with IC, did IC therapies for 20 years. They never worked. And when they did physical therapy with her, the physical therapy was always painful, which is really unusual. Normally, once you start physical therapy, you get better fairly quickly within 3 to 4 to 5 sessions. Things should improve. But in that patient's case, physical therapy was already always quite painful. And so she attended one of these meetings. I always say you're an anatomical mystery to be solved. She went back to the doctor. They did some imaging, either an MRI or a CAT scan. And in her case, she had a giant mass of scar tissue woven through her pelvic floor muscles. And that was the source of her pain. And that's why physical therapy hurt. She was never a bladder patient. She was a pelvic floor patient. Well, hello, we have a new one. So we had a new one. Her symptoms began after she fell off a horse, which means that we're looking at pelvic trauma. We're looking at muscle trauma and or bony structure issues. She had a very bad back, right at L4, L5, probably related in some way to the horseback riding accident. And then the bladder pain started in her 40s. And then when they looked in her bladder, she had Hunner's lesions. So it's always kind of interesting to try to get you guys to focus on the concept of cause versus effect. So the symptoms are the effect, but what's the cause? What's the underlying cause? And that is ultimately your mystery to be solved. And in her case, I have no doubt that the pelvic trauma was the triggering event. But then the next question is why did she end up with big bloody wounds in her bladder that had never been treated? Why? And of course, we now have another very interesting case study about that. We had a woman, this was a case study published in one of the major urology journals about a month ago. So a woman with severe Hunner's lesions who also had a severe prolapse. So her pelvic floor muscles were so weak that organs were falling out of her. And when they had to go in to repair the prolapse, and when they did that, her Hunner's lesions disappeared. Her Hunner's lesions completely disappeared. And in this case study, they said she was cured. And that was our first discussion of Hunner's lesions potentially being associated with a really severe structural abnormality. You know, our theory with Hunner's lesions is number one, it could be a viral infection. We got lots of data to support that. It could be neuroinflammation. But now we really, again, we have to look at the role of bones and muscles and long-term inflammation from messed up bones and muscles. We had a research study a year ago that showed that 70% of the men with testicular pain had an underlying hip abnormality. So we're all now really taking a step back, especially for those patients who are not responding to therapy. And we want to consider the totality of the pelvis. We want to look at muscles, bones, organs, nerves, and blood vessels. All right. So anyway, I've got to send her a big long email because she didn't have access to the internet. So actually, I'm going to send her a big kit of information with a big long letter to me that separates out the pelvic floor versus the estrogen atrophy versus the original horse issue and stuff like that. And that's what we do. And so if you ever want to spend a little bit of time talking with somebody, I'm your lady. I would be happy to do that. You can call our phone number, 1-800-928-7496. Go to the patient assistance line. I usually answer that phone. Just know that it's first come, first serve throughout the day. More than happy to take your questions. No charge behind it at all. But if you want to spend a good deal of time, an hour, 30 minutes or an hour, really going into your case, I would ask you to sign up for a coaching session. Otherwise, few questions, 5, 10, 15-minute discussion, not a problem. Feel free to give me a phone call. All right. So normally when I do these meetings, I do a little 30-minute lecture, which I just did. Then we're just going to dive into your questions. And then if we want, we can do Zoom. I will tell you that I hurt my back again yesterday. And so we'll see how long my back lasts because it was hurting quite a bit. All right. So hello, Lissy. Hello, everybody on Facebook. It's so good to see you. Here, hold on a sec. I have to look over here to see my Facebook questions. Anne says, how do you breathe when you do pelvic floor exercises? You know, I just do belly breathing myself. You know, belly breathing is where as you breathe in, your belly rises. Think about how a cat sleeps. When a cat's sleeping, they're not doing this. They're not going like that. They're actually, their belly is expanding, belly breathing. Hello, Tashona. Trisha says it's hot in Florida. Sylviane, hello, honey. She says, hi, Jill. Just want to say Bladder Builder is finally really beginning to help me. Thanks for the consultation. You helped me more than you know. Sylviane, I'm so happy for you, hon. I'm really glad I was able to help. Hello, Jen. Nice to see you. Hi, Beth. Hi, Melanie. Melanie says sensitive to foods, meds, vitamins, all things. So if you've got exquisite sensitivity like I do, that puts you in IC subtype 5, central sensitization, chronic overlapping pain conditions, right? All right, hold on. It's just so hot here. It's going to be like 105 or 110. So let's just deal with this hair once and for all. All right. Let's see here. Hi, Carolyn. Donna says, I've had IC since 2001. I took Elmeron for years. It helped, but I don't take it anymore. A couple of years ago, I did pelvic floor physical therapy and was healed. You were healed for one. I don't see the rest of that. You know, we knew in 2008 with the publication of the first National Institutes of Health study on pelvic floor therapy for IC that it was far more effective than bladder therapies. And that was the moment the IC movement was turned on its head. Because up to that point, everybody's going, IC is a bladder disease, bladder disease, bladder disease. But if it were a bladder disease, muscle therapy wouldn't help. But the absolute reality is that muscle therapy helps many of us, myself included. Bladder therapy's never helped me. Never. Bladder installation is a total waste of time. You know why? Because my bladder wall's healthy. There's nothing wrong with my bladder. It's my nervous system and my muscles. I'm IC subtype 3 and IC subtype 5. But my bladder is perfectly normal. It's a baby bladder. It looks good. Doesn't mean I don't have pain. It just means my pain's come from somewhere else. Hi, Pamela. Sylviane would love to talk to you again. Just a few questions. Sure, just give me a phone call. Just know that Mondays are my day off. I get one day off a week. It's Mondays. Well, Saturdays and Mondays. Evelyn says, I have IC. Nothing helps. I just suffer with pain. Evelyn, this meeting is for you, hun. This meeting is for you. Exactly. So, do you know what your subtype is? Now, what the American Urology Association says that if you're not improving, you're getting worse rather than better, it's time to take a step back and revisit the diagnosis. Let's make sure we know what we're treating. Because for a lot of people, it's really not the bladder. It's really not the bladder. It's muscles, a fibroid tumor pushing on your bladder, endometriosis, Tarlov cysts. There are other things that can create all the symptoms that you associate with IC. You know, remember, the bladder only knows one language: frequency, urgency, pressure, pain. You could have a bullet wound and it would feel like infection. You could have a stab wound, it would feel like infection. You could have cancer and it would feel like infection. The bladder only knows one language: frequency, urgency, pressure, pain. And the challenge here is that it's easy to keep focusing on those symptoms without understanding that muscles will also trigger those symptoms, and dysfunctional nerves will also trigger those symptoms. So we've stepped way back from this concept of IC as an incurable bladder disease. We really just don't go there anymore. Now we have very clear variants and subtypes: bladder-based, bladder-centered, and beyond bladder-centered. Those are the two ones that everybody in the world agrees to at the research level. And then, of course, I use a system that was created by Chris Payne that focuses on 5 core variants for IC. Hunner's lesions, that's number 1. Hunner's lesions. Number 2, bladder wall driven. Number 3, pelvic floor driven. Number 4, pudendal neuralgia. Number 5, central sensitization, chronic overlapping pain conditions. Good morning, Linda. Donna says, she said that I developed cervical cancer and the IC came back. I had a complete hysterectomy and the IC is back. I tried pelvic floor, but it didn't work. Should I keep doing physical therapy? Or is there something else you can recommend? My surgery was in January 21. I did try estrogen cream, but it didn't work either. Okay, now, Donna, girl, number 1, I'm sorry you had to go through that. I went through it 4 years ago myself. And I'm telling you, recovering from a hysterectomy is a beast, and they're not lying when they say it's a 1-year recovery. It is an undeniable fact that when you have pelvic floor surgery, pelvic surgery, your pelvic floor muscles are affected. I had involuntary pelvic floor spasms for 10 months, and I needed physical therapy to stop them. And so your goal with pelvic floor physical therapy is to try to make sure that the muscles are relaxed and calm. But here's the other reality is that, girl, you are now in menopause. You're postmenopausal. Your hysterectomy put you into total menopause. What does that do to the bladder? Unfortunately, it makes the bladder more vulnerable. Your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to protect the tissue, right? We call it the mighty mucus. Because when you think about it, the bladder is the only organ in the human body that holds toxic waste, right? Because urine's body waste. Urine contains ammonia and urea and all sorts of irritants. So how does the bladder protect itself from all those irritants? It's because there's a big, thick coating of mucus on the bladder wall that protects it. It acts as a barrier. Unfortunately, that mucus is estrogen dependent. So when you're young and you have lots and lots of estrogen, you have lots and lots of mucus, and you can get away with stuff. But if you're on birth control, if you are in chemical menopause, taking Lupron for endometriosis, or if you're perimenopausal, menopausal, or postmenopausal, your estrogen levels are changing now. What that means then is that your bladder's ability to defend itself is now compromised. That's not a disease. That's aging. It's called the genitourinary syndrome of menopause. And so you say here that you tried the estrogen, it didn't work. You have to ask yourself, what are you expecting the estrogen to do? The estrogen does not turn your pain off right away. The estrogen gives your cells what they need to produce mucus, and you should be using it. If the doctor gave it to you, you should be using it, but it's not going to turn off the pain like that. It works over time, but it keeps those tissues nice and healthy. But I don't think, again, I had my hysterectomy in May, and I was at my gynecologist and I wouldn't let anybody touch me. I had a terrible amount of pain around my cervical incision where my cervix used to be. I would have slugged somebody if they tried to do pelvic floor physical therapy for me in the first 6 months. I was way too tender. We started physical therapy in December, and it turned all the pain off eventually. So if you want to talk about it, Don, I'd be happy to talk to you sometime. Cindy on YouTube says, hi, what's the best time to call you? I'm interested in setting up a coaching time. So guys, first come, first serve. Our phone number is on our website, 1-800-928-7496. I generally start answering the phone around 11 a.m., but I'm doing elder care. I really start diving into coaching and returning phone calls after 1 p.m., and I will return phone calls all the way up to 7 or 8 p.m. Pacific time. Okay, so call and leave a message. Or you can go into our store and get buy a coaching session if you want to do that. Okay, but I try to return everybody's phone calls. I had Friday 15 phone calls to return, and I returned them all. Oh my God, you guys. Oh my God. You know what? I love my job, but there are moments when my job is challenging. Now somebody's calling me right now, and I'm not going to. Let me just look at it. Okay. I'm not going to answer that phone because we're doing a live stream. Sweet, sweet elderly lady who was almost deaf. And I spent 30 minutes yelling at the top of my voice into my phone so she could hear me. I couldn't. She was a sweetie pie. Loved her. Yeah, so call on Tuesday. Don't call tomorrow because I'm not going to do any coaching tomorrow, except for somebody who already signed up. Anne says, let's see, hold on. Jessica says, I was diagnosed with IC 6 years ago. We're all in this together. We are absolutely all in this together. And there is strength in numbers, my friend. There are strength in numbers. Trisha, thank you so much for the 99 stars. Really appreciate that. Really appreciate your support. Jessica says, how do you get a membership? You just go on over to our website, icnetwork.org. And you can go into our shop. Just click on our shop and you can get your membership there. Anne says, can I take Claritin today if I get the vaccine tomorrow? I have no idea. I don't think so, though. If I remember correctly, they did not want you to take an antihistamine like 24 to 48 hours before the vaccine. I might be wrong. Hon, Google it or call your doctor. I don't know, to be quite honest. Trista says you need to take, girl, I need to take days off. I do, no doubt about that. Jessica says, I was told by my primary doctor that I'm vitamin D deficient. Yeah, me too. I'm vitamin D deficient also. Your levels are very low, so are mine. And that's fine. You can absolutely take vitamin D every day. I take vitamin D every day. Vitamin D as in dog is not irritating to the bladder. I would be stunned if anybody flared from it. The only vitamins that irritate the bladder are vitamin C in the form of ascorbic acid or vitamin B as in boy 6. Rhonda says, Jill, you always look nice. I have you on my living room TV. Hello, everybody. You're not any better. You're actually worse. Your doctor ordered phenobarbital. Okay, good. You feel like somebody kicked you in the gut. Yikes, girl. Are you having you think it's a flare or do you think it's a UTI? You guys, you have to refresh my memory because I work with so many patients that I might have known your story a week ago, but I might not remember it. Pamela says, my doctor says IC bladder, no test really on it, 18 years of pain, many doctors and physical therapy over 12 years didn't help. You have an IC bladder, overactive bladder, pelvic floor burns, vulvodynia, fibromyalgia, pudendal nerve, arthritis in your pelvic area and right hip, opening of the vagina hurts, can't be touched, and more. Now mouth and gums swollen for over a year, dry mouth. Okay, so Pamela, so you just kind of de facto diagnosed yourself as IC subtype 5, central sensitization, chronic overlapping pain conditions. Anytime you've got more than two or more pain conditions, that puts you in a new diagnostic category, chronic overlapping pain conditions. And so you've got your IC bladder, you've got vulvar pain, you got fibromyalgia, you are in that group. That is a central nervous system dysfunction. And then you've got some pudendal nerve issues, which means you also have some muscle issues, because the pudendal nerve is generally compromised by tight muscles. And it's no wonder that you have tight muscles, given the fact that you have so many pain conditions. You guys, you have to remember that, anytime you're in pain, your body takes over and it tries to protect you from the pain. And the way that it does that, it's through the guarding reflex. It will tighten muscles in the area to try to prevent you from walking on the broken leg. Or in the case of pelvic pain, to try to prevent you from moving in a way that might hurt it. So, and now you've got your mouth and gums swollen for over a year. And I would have to wonder, remember, we just talked about that as a symptom of a vitamin C deficiency, which would be interesting. You need to read the article. Let's see what that says. But what are you doing for your central nervous system, hon? What are you doing for that? Because bladder therapies are not going to fix the overlapping pain conditions. We have to work at this. We have to work at the brain and the spine to calm those oversensitive nerves. I've talked about that in depth in previous meetings. I'm happy to talk about it again, but let's go through a few more questions first. Tricia says, I also take vitamin D and going outside. That's right, because your body does so. Produces vitamin D in the sunshine. Oh, that's right. Rhonda, you've got the gastroparesis. Yeah, I feel your pain, honey. I feel your pain. Are you able to eat at all? And do they have you on any medications for your gastroparesis? Valerie says, my oldest left for college today, 600 miles away. I'd been good most of the year, but I think that the stress of this day is finally showing itself and I feel a flare up starting. Okay, so Valerie, let's go into our flare rescue plan here. So you're going to if you're having a stress induced flare, it's time to take a step back, do some simple mind body medicine, get outside, get in the sunshine, try to take a walk, try to do a nice relaxation exercise. If you can Over on our website, IC Network, we have got all of the guided visualizations for progressive relaxation for IC patients. They're all free, and you can find those under self-help. I would be doing a couple of those. It's hard to watch family go away, especially in a year like this year. But carry hope, my friends. We want our children to fly. We want them to create wonderful lives for themselves, right? And sending them away to college is a big part of helping them learn who they are and learn what's important to them. Evelyn says, they told me it's like a sunburn on the bladder wall. I haven't really ever heard anybody ever describe it like that. That makes I mean, it's not like the bladder wall's burned. I mean, it's not physically burned, but it could be chemically burned. Like if you were drinking diet soda, if you're drinking energy drinks, lots of coffee every day, or going through chemotherapy, then you have the equivalent of a chemical burn on your bladder. It's called chemocystitis or chemical cystitis. Jessica says, I was bucked off a horse when I was 10. I wonder if that may have caused it, although it was a long time ago. Honey, we're finding, it's interesting because horseback riding has long been debated and discussed in support group meetings. We've had many, many discussions about it over in the IC Network forum over the years. And I remember two people got into a really wicked fight about it, and I had to step in and stop both of them. One of them said, horseback riding perfectly safe. The other one said horseback riding is very, very dangerous. And again, it kind of depends upon your subtype. If you've got pelvic floor pudendal neuralgia problems, yeah, riding a horse is probably not going to be the best thing you could do, just like riding a bicycle would not be the best thing for you to do. But sometimes those early injuries and traumas set the foundation for all of this. All of this. So Rhonda, did they give you meds? Did they give you meds for your gastroparesis? Are you able to eat anything? Okay, so they gave you the phenobarbital for that. You suffer really bad after you eat. So for anybody who doesn't know, gastroparesis is delayed stomach emptying. It means that the nerves in the stomach are quite slow, and it's not allowing food to pass through in a timely way. So what happens is that food sits in the stomach for a longer period of time where it starts to ferment. So what happens with people who have gastroparesis is you end up with a lot of gas in your stomach, and then you end up belching a lot. And it's just really awful. I mean, if it gets really, really severe, you really struggle with eating because anything you put in there is going to be challenging. I don't know if they still use Reglan. That's what they gave me, Rhonda. Reglan. I did that for about 4 weeks, but Reglan has a lot of really dangerous side effects. But that's what got my stomach moving again. That happened to me, like 10 years ago? Where just suddenly out of the blue, I started being very, very gassy, and then it got worse over time. And then I ended up in the hospital. The heart racing because I hadn't eaten or drunk anything in a period of time. And it was scary. It was scary going through that, but my stomach is much better now. I just don't eat those foods which are hard to ferment. I mean, that will start to ferment or that are hard to digest. So I personally don't eat leafy greens. I don't eat spinach or lettuce, but I eat a ton of salads like cucumber, carrot, beet, mushroom, avocado, and the best salads in the world that's IC friendly is cubes of avocado, cubes of beet with some shredded carrot. Oh my God, it's so good. It's such a good salad. So IC friendly. Thank you, Julie, for the 99 stars. I really, really appreciate it. That's very sweet. Thank you for your support. I think what I would like to do is I would like to go over one of these articles. Let's just do this. Tabitha says, I'm in Virginia getting solar therapy treatments. The third treatment hurt so bad, and the doctor used a small specula and could see your pelvic floor is so thin it was tearing, and you have open wounds, which is why it was bleeding and hurting so bad. He put you on estrace vaginally. Right. So that's what happens as we get older is those tissues down there get really, really, really dry. And then they start to tear, just like your skin. For people who are older, their skin gets very easy to tear. But so does the skin inside of us. The skin in your vagina, on your vulva, can also tear quite easily, especially with intimacy. And so one of the best things that you can do to help that tissue get strong, again, is to use some topical estrogen, because that skin will immediately start using that estrogen to produce mucus. It's very, very important. And if you can't use estrogen, then you're going to need to do something like coconut oil and like that. Coconut oil or V-Magic. V-Magic is really popular. Let me get it so you can see it. Where is my V-Magic? Oh, here it is. So some of you cannot use topical estrogen for one reason or another, either a risk of cancer or blood clots or something like that. It's true, people are sensitive, but you don't want to leave that tissue dry. If you leave that tissue dry, it's going to be painful. Think about how dry mouth feels. Dry mouth hurts. You don't want dry vulva. That hurts too. So one of the really popular products is made by a company called Medicine Mamas, and it's called V-Magic. And it is organic extra virgin olive oil, organic extra virgin avocado oil, organic honey, sea buckthorn oil. And this is about it's the perfect consistency. Super, super light. It feels exactly like your normal mucus would feel. It's really, really popular and effective. So if anybody wants to try V-Magic, we have this in our shop. V-Magic. And see, look, it's not going away. It's going to put a nice coating over those dry tissues. And if you don't have V-Magic, then get some organic extra virgin coconut oil and use that. The nice thing about the coconut oil is it actually has natural antifungal, antiviral, and antibacterial properties. So coconut oil is not a bad thing too. Let's see here. Jessica says, what is Bladder Builder and where do you get it? Bladder Builder's in our shop. Let me show it to you. Let's see. Where's my bladder rest? So let's kind of go over the history of supplements and what's available now, just so that you kind of understand context, okay? So the first thing you have to know is that the American Urology Association, in their IC guidelines, want patients to try supplements before they try oral medications or bladder installations. Why? Because they have far fewer side effects. Think about the side effects of Elmeron, which causes blood thinning. It can cause changes in liver enzyme levels. And of course, now we know Elmeron can damage your retinas. And so if you look at the AUA guidelines for IC, 6 steps of treatment, they want you to do the easy stuff before you do the hard stuff. So you do everything in step 1 before you go to step 2. You do everything in step 2 before you go to step 3. So in step 1 is all the self-help stuff. Making sure you're drinking plenty of water, that you're staying relaxed, that you're modifying your foods, and to try the supplements. If those don't work, then you go to step 2. Step 2 is oral medications, bladder installations, and physical therapy. If those don't work, you go to step 3, which is Hunter's lesion therapy, hydrodistension. If that doesn't work, you go to step 4. And in step 4 is neuromodulation or Botox. And if those don't work, you go to step 5, which is cyclosporin. And if that doesn't work, you go to surgery, right? But most people never get to surgery. And there's obviously kind of pros and cons for everything. But just understand the context here. It's not me saying this. It's the American Urology Association says the supplements have enough of a track record with research behind them that they're worth considering. So the first supplement that really took over the IC world was a supplement called Cystoprotect. It has chondroitin in it for the bladder wall, hyaluronate for the bladder wall, and it has quercetin in it with a nice antihistaminic effect. This was created by one of the top federally funded IC researchers, Dr. Theoharis Theoharides at Tufts University over 20 years ago. And it's very interesting how it happened because the state of Massachusetts asked him in his lab to study the safety of supplements. And as he was doing that, he was like going, oh, I wonder if something might help IC patients. And so he took the knowledge he got from doing this safety study and he created Cystoprotect. And Cystoprotect was by far the top supplement for over 20 years. But we've learned a lot about IC since then, and Dr. Theo could not update his formula because by this time they had sold the licensing rights off to another company and he had a non-compete agreement. So he has not been able to update this formula, although he is now thinking about doing that. So the next supplement that came out was a supplement called CystoRenew, which is up on my shelf. And CystoRenew took the same ingredients, but it added a couple of things that would calm nerves. It added a little bit of lemon balm in it with a little bit of aloe in it. So when CystoRenew came out, a lot of people moved from Cystoprotect to CystoRenew. And it makes sense because now we know that nerves play a much bigger role in IC than we really realize. That a lot of us, especially IC subtype 5, it's all about super sensitive nerves. So we want to do things that will calm the nerves down. Well, CystoRenew did not really fill that void. And so another company came along called Natural Approach Nutrition. And Natural Approach Nutrition is run by a gentleman who also has pelvic pain, although he didn't have IC. He was a surgical malpractice patient who suffered terribly. He's better now. We got him through 13 surgeries trying to restore damage done by a doctor who did surgery on him. And he came to me and he said, I want to help. I had no idea people could suffer. And he put together a team of people. I was on that team along with a couple of top IC researchers and other urologists and just tried to revisualize supplements possibly and to think if was there something else that might make a supplement a little bit better. And the result of that team, it was a 2-year discussion, was a bladder builder. So bladder builder has many of the same ingredients as Cystoprotect, but more. It has beneficial probiotics in it for the gut. It's got some amino acids in it. But what makes this the top supplement now is it has PEA in it, which in 2019, we had our first ICPEA study, which showed that it was remarkably successful at calming nerves down and reducing pain. So PEA stands for palmitoyl ethanolamide. It's been used in Europe for a variety of chronic pain conditions, massive research studies on it. And so in 2019 at our AUA conference, Italian IC researchers brought a PEA IC study to the United States and presented it at this big international urology conference. And the data was nothing short of astonishing that by month 3, 87% of patients using PEA reported a significant reduction in their pain. And by month 6, a good 20-25% were completely pain-free using just PEA. And people ask me what I use. That's what I use is I take Piora PEA because my bladder is healthy. It's not my bladder wall is not my problem. My problem is my muscles and my nervous system. But Bladder Builder does both. So Bladder Builder has ingredients for the bladder wall combined with ingredients that can support the gut, combined with a pain-fighting ingredient in it, PEA. So last year we did our 1-year follow-up study with this, and we published that data on our website. 60% of the patients who tried it love it, and they're still using it today. And they reported less pain, fewer flares, shorter flares, less painful flares. 40% who tried it stopped it. They stopped it because either they couldn't afford it, or their doctor wanted them to do something else, or they had a gut-related side effect, which any of the supplements can cause. All the supplements are associated with a little bit of gut distress. That's the nature of the beast. So the chondroitin, even with me, when I took Cysto Protect, I could only take one a day. I couldn't take 2 or 3 a day because it gave me diarrhea, right? But I could handle one. So any of these supplements have the ability to irritate the gut or the stomach. So you always try one, see how you do, et cetera, et cetera. So anyway, Bladder Builder is a viable option. And so this would be ideal for somebody with IC subtype 2, bladder wall-driven estrogen atrophy, or chemical-induced cystitis. But if you flare when you take probiotics, or if you flare when you eat yogurt, then you should not do this one, because this also has probiotics in it. So that brings us to the next one, which is bladder rest. Bladder rest is a really simple, clean formula for people who are super, super sensitive. Same ingredients as Cysto Protect, pretty much the same ingredients with a few more, but instead of it being in a olive oil base, it's in an avocado oil base. And so this was designed for really, really sensitive patients in mind. Aloe has a place. Aloe has been around for quite a long time. Aloe is known for having a bit of a soothing effect. And so the aloe that we suggest is a combination of aloe and PEA for the pain fighting effect. So this one kind of takes aloe to the next step. It has the calming and soothing effect of the organic anthraquinone-free aloe, combined with the pain-reducing effect of the PEA. And PEA stands for palmitoyl ethanolamide. I'm going to type it. I'll type it in your chat. Okay, and I'm going to give you a link. I'm going to give you the link to the National Library of Medicine. Go to http://pubmed.org. Okay, and then copy and paste that in, and you can look at all the studies. It's amazing. The thing that stunned me the most after the 2019 study came out is I went through about 30 studies, and there were virtually no side effects. Only one study reported side effects. Palmitoyl ethanolamide is a simple fatty acid, very, very well tolerated. And the consensus among the researchers is it's the best for nerve-driven pain. Donna says, they say cranberry juice is good, but I find the acid irritating. Of course, cranberry juice, listen, the cranberry juice companies want you to believe that cranberry juice is really healthy for the bladder. It's not healthy for the bladder. For those of us who have bladder wall injuries, cranberry juice is too acidic. We call it the acid bomb. Jessica says she's been trying to find aloe without vitamin C. This one, yeah, this one, hun. Allopath, you can get it right in our store. Sherry says, sorry if this has been discussed in the past, but what are you hearing about the COVID vaccine and mast cell production and bladder reactions? I can tell you, Sherry, that at this point in time, I don't believe that any IC researchers are studying the vaccine and its impact on IC at this point in time. We have a study that's been studying the effect of COVID on IC, and let me tell you, it's pretty bad. In our study of IC patients who get COVID, 75% of patients who get COVID have bladder flares. And for 25%, it is a very severe bladder flare that can last for months. And that is because we believe that it's either inflammation from COVID or that COVID has actually infected the bladder wall. Why do I say that? Because we already have 4 research studies that have found live virus in kidneys, and we have 12 research studies which have found live virus in urine. So it's not a stretch to think that the virus could also be infecting the bladder wall. So that's one of our guesses. Informally, I will tell you here in these support group meetings, a lot of people have asked about the vaccine. Of course, you have to weigh the pros and cons by talking with your doctor. Once I started learning more about the effect of COVID on the bladder, I knew I wanted to get the vaccine right away because I did not want to have my bladder wall damaged. Um, uh, my guess, and this is purely a guess, is about 90% of the patients who get any of the vaccines are perfectly fine. Like I had the Pfizer, not a problem at all. Did not bother my bladder at all. But about 10% of IC patients, and again, that's just a guess, are reporting flares with the vaccine. We don't necessarily understand why that flare is happening. And it appears to be a 2 to 4 week flare before things calm down. That's all I got for you. I did talk with Dr. Theoharides about that. He has a protocol that he is suggesting for people who have COVID, um, and um, and again, it's kind of a combination of things that calm nerves down, et cetera, et cetera. I also saw a new protocol yesterday that involved taking higher doses of vitamin D as in dog, combined with higher doses of lysine, combined with a few other things. What Melissa says, what's a multivitamin for IC patients to take? It is called Bladder Smart. Let's see. Here it is. So the low acid vitamins, it's always interesting the impact we all have in our lives. Here, hold, Nicole, you wanted that palmitoyl ethanolamide, right? And go to pubmed.gov to look at these studies. Okay, so here, HTTP. All right. Okay, so years ago, I'm going to say about 15 years ago, I was having a chat with the CEO of Far Laboratories that made one of the early supplements. And he said to me, he said, Jill, if you could make anything for an IC patient, what would you make? His name is Al Rodriguez. I went, I know exactly what I'd make. I'd make a low acid vitamin. He goes, why? And I said, because every single day I had phone calls from people or emails from people. What is a bladder friendly low acid vitamin? And my answer was always none. There was none. Well, he called me back 6 weeks later and he said, we've made you your low acid vitamin. I was like, great. That's awesome. It was called Multi-Right. Multi-Right. And we sold Multi-Right for many, many years. And it's still available on their website. The challenge with Multi-Right is that the pill is huge. And I don't know about you, but I really have trouble swallowing bigger pills these days. I'd have to cut it in quarters and then it'd have sharp edges and it'd irritate everything. So I asked the same company that makes Bladder Builder if they could make us a new low acid multivitamin. And they did a couple years ago, and it's called Bladder Smart. And what's cool about it is it's a third of the size. It's in capsules now, and you can take up to 3 capsules a day. I take 2 a day. But unfortunately, it keeps breaking the pill filling equipment at the bottling factory. And so they're going to start making it in a small pill. But the whole point here is that it's low acid, super easy to tolerate. Whether it's in a capsule or pill, it's very gentle on the bladder and certainly worth trying. I love it. It's like the first vitamin aside that I can take. Whereas the Multi-Right, again, I just couldn't swallow it easily. And I had a lot of complaints from people about it. Laura says, I had COVID and you can't get rid of the flare. Yeah. Laura, I'm so sorry. There's still so much that we need to know that we don't know about what happens with COVID in the bladder. And we don't know if it's just an inflammatory reaction or if you still might have a little bit of virus that might be active in your bladder. Um, I do have a protocol from Dr. Theoharides that he was suggesting. Let me see if I can find it. Hold on. Let's see here. So I was talking with them about long haul COVID. So what he was recommending, now he's getting together with Dr. Whitmore to try to write something on this for a journal. He's suggesting 2 Cysto Protect twice a day, a Protect, 1 Fibro Protect, 1 a day, 10,000 units of vitamin D3, 10 milligrams of Zyrtec, and 20 milligrams of Pepcid once a day. That was his suggestion for patients. And then I found yet another one that was very different yesterday. I think putting a lysine in there is really, really important because lysine interferes with viral production. And for anybody who has active COVID, not using anything that contains arginine until the COVID is gone because arginine enhances viral replication. So that would include some of the supplements. Sherry says, it's about my husband. He has everything: Hunner's lesions, mast cell growth, bladder scarring, etc. So Sherry, number one, this is what we know about Hunner's lesions. They normally respond to Hunner's lesion specific therapies. That means cauterization, laser therapy, or steroid injection directly into the center of the lesion, or hyperbaric oxygen therapy, which kind of floods the tissue with oxygen to enhance healing. Of course, we have Liris, Liris, which is the first treatment in history to heal Hunner's lesions. It's just not available right now. But most importantly, Sherry, some of the new research is researchers from Europe were the ones who first discovered that some patients with lesions have active viral infections, polyoma infections in their bladder wall. Polyoma infections, where it's not a sexually transmitted disease, you don't have to worry about it in that way. It's a normal part of the human biome, and it gets turned on in people who are immune compromised. And so polyoma hemorrhagic cystitis has long been a thing for people who are in immunosuppression drugs. So if you ever have a kidney transplant, some type of organ transplant, and you're suppressing the immune system, the polyoma virus becomes active and causes a bleeding lesion where it's active. So the Europeans found polyoma virus in the urine of patients with Hunner's lesions, and then Epstein-Barr, and then a couple of other. That was about 5 years ago. And then our own National Institutes of Health did their own viral study for 5 years. And what do you think they found? Polyoma infection also in a small subset of patients. So I think it'd be really, really interesting to have a next generation urine test to see if there's any active virus in his urine. I emailed another one of our board members, Dr. Kim Peters, because I had a patient who contacted me who had 2 Hunner's lesions treated and 6 new ones immediately grew, which is really rare. It's like normally when you treat a lesion, the lesion calmed down slowly but surely. But in her case, it just exploded. She had a lot more lesions. And we brought up some of the new viral research, as well as she was on a medication. There was a medication involved that could also trigger some of those. And anyway, he shared with me that they're working with the Pathnostics laboratory to look at to look more at viral infections in some of these patients. Okay. Zelda said, just tuned in. After 6 months investigation, you found out you have, was it Candida krusei? Thought it was a regular yeast infection and was taking lots of fluconazole, which doesn't work for it. It got worse. Girl, I got to tell you, I mean, like 8 or 9 years ago, the Center for Disease Control issued their top 10 threats to public health due to antibiotic resistance. And I think the third one was actually drug-resistant candida infections. Usually candida glabrata infections are the ones that are known for being the most drug-resistant, but you've also got a real serious fight on your hands trying to get rid of that candida. Hopefully, hon, you've really reduced the sugar in your diet, the carbs in your diet, because candida need that to eat. And so it's very, very important that we not give the candida the food that it needs to grow. Oh, you're now using triconazole cream and estriol cream, and your IC symptoms are almost gone. Yeah, baby. We love success stories. So in your case, you may, instead of having, quote unquote, this mysterious incurable bladder disease, what you have is a super drug-resistant yeast infection in your urinary tract, which again, everybody now realizes that happens. Again, it was our own National Institutes of Health who discovered 5 years ago that many patients who were flaring because they had candida in their urine. And I did an article on that. We've talked about that for 5 years, every meeting. You can find that article over on our website. Just go to icnetwork.org and search for candida, and I'll show you the research. It's from our own National Institutes of Health. So the PEA formula that matched the formula in the research study is Peora. And what's cool, so imagine we finally have a supplement with a proven track record of reducing pain, right? PEA. With the research to back it up, many research studies to back it up, with PEA being found effective at reducing fibro pain, sciatica pain, burning mouth pain, IC pain, and they're even studying it with acute pain from injury. And it is ironic that this is literally the most affordable supplement ever in the IC world. It's just like $24.99 for a month's supply, whereas most of the other supplements are in the 30s or 40s. And they're getting with COVID and all the manufacturing delays, things are challenging. It's a 5-month delay. When we place orders, we don't get it for 5 months right now. So we're trying to estimate 5 months in advance. We did just get, finally, after literally 9 months waiting, we just finally got our big Cystro Protect shipment. So if anybody wants Cystro Protect, we've got in singles, 3-packs, 6-packs, and I think even a 1-year supply in our store if you want it. And they're all discounted 5, 7, 10, 12, 15% off. So Laura says, where can I find the steps that you listed, steps 1 through 5 at the beginning? They're right on our website. I have a video on it, but let's just do it. So the steps of treatment are in the American Urology Association guidelines for IC. So you want to go to auanet.org, auanet.org. And in the upper right-hand corner is a link that says guidelines. Click on the link, go to that page, then search for interstitial cystitis. And everybody should read those. Listen, the guidelines are pretty good. I mean, they were written before subtyping, so you can see where they're going to be adapted a little bit. I think they're working on adapting them right now. But it's the purpose of the guidelines, and again, they were released in 2011, was to provide a standard of care so every doctor knew how to treat IC correctly, instead of it being this crazy random, some doctors treating it with InterStim at the first appointment, other doctors telling patients there were no treatments and sending them on their way. So, Angie said, just had a cystoscopy to check why there's blood. She didn't find anything unusual. She said the blood was from dryness. Started estrogen cream a few weeks ago. How does that work? Blood in your urine and vaginal dryness. She takes urine. She takes a urine culture by catheter. So if the urine doesn't pass over the dry, actually it's passing over the dry vulva. Well, it's cracking, hun. Listen, your skin down there is meant to be very, very moist. And think about the bladder. I mean, the bladder expands, and then it contracts. It expands with urine, and then it contracts. And a big part of that process and what makes it so good at the job that it's doing is because of this really nice thick coating of mucus. It's very, 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 very moist. I mean, it's kind of a mystery as to how the cells contract and expand. It's a fascinating biological process, but I can tell you that moisture is a critical part of it. So just like you would get cracked lips if your mouth was dry and your lips would dry, well, you're going to get cracks in your bladder potentially, and they actually call them cracks if you get super, super dry from estrogen atrophy. It happens all the time. You can have bleeding in your vagina after sex. You could have bleeding on your vulva after riding a bicycle if you're super dry, or riding a horse. You could have bleeding in your urethra, and you can certainly have a little bit of bleeding oozing in your bladder if your skin quality is very, very poor. Graciela on YouTube says she had the cystoscopy and her bladder looked good. All right. So Graciela, if your bladder looks great, good. So let's take a step back from the bladder. And now we have to consider other structures that could be triggering your symptoms. You guys, don't be freaked out if they say your bladder's fine. It's like, okay, that's good news. It means my bladder's healthy. There's nothing wrong with my bladder. My next question is going to be, all right, well, what's triggering my pain and discomfort? If it's not my bladder, what is it? And usually it's pelvic floor muscles or a fibroid tumor or endometriosis, something related to the reproductive tract, or pudendal neuralgia, something like that. So Gracie, that's good. It's going to help you narrow down what you need to do. You wouldn't want to waste time doing bladder installations if your bladder wall's healthy. Now we got to take a step back and figure out what else could be doing that. Hello, Donna. Nice to see you, hon. Please say hi to your mom for me. Yeah, Graciela, absolutely. That's fine. That just puts you in another subtype. It means you're not IC subtype 1 or IC subtype 2. You're IC subtype 3, 4, or 5 instead. It's either your pelvic floor or your pudendal neuralgia or your central nervous system or something else happening in your pelvis, like a scar tissue or a broken tailbone, a bad hip. Could be anything down there. That's where it gets challenging, is we got to figure it out. You are a mystery to be solved. Angie says, so will the estrogen help replace the moisture? The estrogen is what the cells use to create moisture. So it doesn't replace it. It's like an essential ingredient of that moisture making process. So the estrogen cream will be immediately absorbed by those cells, and it will be used to produce more mucus. Graciela says, when can I have a meeting with you this week? Tuesday, anytime this week, from Tuesday on. Hold on. I think I have my only day that I'm not going to be available is Thursday, probably until about 2. I have to take my dad for a post-op discussion about his pacemaker. Laura says, "Oh my, you just saved me a lot of pain and pain money and discomfort because my cystoscopy was fine, and they were talking about installations." Well, Laura, installations are a viable option, but it's kind of like that's what's the adage, when you just throw stuff at it and hope one of them sticks. Um, it's very important now that you have a pelvic floor assessment, and let's see what's going on with your pelvic floor, and see if that could be part of the problem, and other things like that. So I'm not saying that the installations are inappropriate. I'm saying it's a little, I mean, if you had visible bladder wall irritation, then yeah, man, we'd dive into those bladder installations right away. But I think the question you're going to be asking your doctor is, why would this be helpful if my bladder's normal? I hope that makes sense. All right, so let's go over these 6 steps to treatment here real quick. Graciela says, "Where do you register to talk to me?" You can either call us directly. Just go to our website, icnetwork.org, or you can go into, if you want to talk for a longer period of time, go into our store and sign up for coaching. It's under wellness coaching. Melissa says, any suggestions on how to explain to your employer and coworkers about IC? Working with IC can be a challenge, especially with so many trips to the bathroom. And hold on, let me get Melissa. I'm going to go back to that. Erica just asked a great question. Has anybody done the mini retreat at Beaumont with Dr. Ken Peters for pelvic floor dysfunction and had success? Yes. Erica, that is literally he's one of the top doctors in the United States. And for people who are traveling, what they do is they set up little kind of mini retreats where you can stay there for a couple of days at a local hospital and go into the clinic and work with the experts, and not only getting a good diagnostic workup, but getting pelvic floor therapy. Really, Beaumont Hospital is, in my opinion, the top IC research center in the United States. They have one of the best diagnosticians in the United States, Dr. Ken Peters, who's the chairman of the urology department at Beaumont. And I sent a lot of people to him because, like, I sent a Denver Bronco football player to him a couple years ago, who suddenly developed all the symptoms associated with IC. If you're anywhere in the Midwest and you want a second opinion, then he's right outside of Detroit, up in Royal Oak, Michigan, would be a viable second opinion for you. If you're on the East Coast, if you're in North Carolina, South Carolina, in that area, you would be going to see Robert Evans at Wake Forest. And if you're up in New England, it would be Robert Moldwin on Long Island. Those are our top 3 doctors in the United States. If you're out here on the West Coast, I've got bad news to share, and that is that Dr. Christopher Payne is retiring. And they are winding down their clinic. It will be closed by the end of the year, and we have nobody to replace him now. So more on that later. All right, so let's get back here to these 6 steps to treatment. All right, these were 6 steps of treatment. They were put together over 2 years by a panel of IC experts, from doctors to researchers to patient representatives. I was not on this panel. That's okay. I don't need to be on this panel. Released in 2011, revised in 2014. I was on the U.S. Army research panel for about a decade. All right, you can find these guidelines at auanet.org. auanet.org. In the upper right-hand corner of their website is a link that says guidelines. Click on that, then search for interstitial cystitis. Everybody here should be reading those. And I think you need 3 copies. It's about 60 pages long. It's worth printing out. You need a copy for you that you can highlight, because it has all the research supporting all the treatment suggestions. And if you got a doctor who's just saying there's no treatment for IC, or the only treatment's Elmeron, man, you slap the AUA guidelines down in front of them and say, hey, man, have you read these? These have been out for over 10 years, 10 years exactly. And a lot of local doctors don't even know about it because they don't go to the conferences and they don't read the journals. So having the AUA guidelines written is really powerful. So keep a copy for you. Make a copy for your urologist, so you can just give it to him and say, I'd love for you to have this, because I don't know if you really have seen the revised version. And then you always carry an extra one in your car or in your emergency go kit. If you have to go to the emergency room for another reason and they don't know what IC is, slap them the guideline. Just, here you go. Here you go. I was working with another guy yesterday who had a doctor again say that IC wasn't real. It's all in your heads because this was an older doctor who had long retired, and that's what they were trained in medical school. But they stopped training that in 1980. IC is real, and not only is real, it's a very, very complex. It's very, very complex, and we put almost $200 million for ICU research into it by our U.S. government. And again, it is considered a condition which affects combat readiness, which is why the U.S. Army studies it also. All right, so let's go through these steps. Step 1, water intake. Now let's be honest here. Some of you don't like water and you just prefer to drink soda. That is a mistake because your bladder was not designed to take massive amounts of acid all day. Remember, your bladder was designed 5,000 years ago. Today's modern day drinks, drunk in quantity, will take a toll on the bladder. The acid will slowly start to inflame and irritate and potentially even eat away at the bladder lining. Number 2, in step 1, diet modification. Come on, you got to change your diet. You got to lose the sodas, lose the coffee, lose the multivitamins, et cetera, et cetera. You can learn more about that on our website. Number 3, supplements. They want you to try the supplements. Again, their own researchers did some of the foundational research on this, Dr. Theoharides. Okay, number 4, muscle relaxation. Number 5, acupuncture. If acupuncture helps you, power to you. Go for it. I didn't find acupuncture helpful. I found acupuncture to actually be a little bit more irritating, but I'm IC subtype 5, and that nerve stimulation was too much for me. All right, step 2. What's in step 2? Physical therapy, oral medications. So the oral medications are going to be the Elmerons, which of course we're really not using too much anymore. The antihistamines like Vistaril or Atarax. And then the antidepressants like Elavil, imipramine, nortriptyline, but they're not giving it to you for depression. They're giving it to you because in low doses, antidepressants calm nerves down. Do not be offended if somebody says, hey, have you tried Elavil? The challenge with the antidepressants is they have a hell of a lot of side effects. And I couldn't do them. It really messed my heart up for years afterwards. Graciela says, is Elmeron an antibiotic? No. Elmeron provides a coating effect to the bladder. It's like a chemical Band-Aid, the same thing that the supplements do. The supplements also provide a bit of a coating effect. And then last but not least, pain care. The American Urology Association absolutely wants pain to be assessed at every appointment. They know that pain left untreated will only escalate and involve more nerves and more tissues. So they're very aggressive with their pain care. They want patients to have their pain treated. And again, this is where you having a copy of the AUA guidelines is really useful. As an example, they support the use of opiate medication. They do. There are times when opiate medication is perfectly appropriate for patients who have severe pelvic pain, but that just can't be your end all. I mean, if you've got to take pain medicine, you still have to be doing other things that will treat the cause, right? You have to focus on the cause. The worst thing you can do is go to a doctor and say, I need pain meds. You will look like a drug seeker. When you go to a doctor, you're going to say, doctor, I can't function. I can't go to work. I can't sit in a car. I can't shop. I can't make food because my pain is so severe. What can we do to make me more functional so that I can do my daily activities? And that's when you give them the opportunity to say, well, maybe a little pain medicine would be appropriate. Got to be it's not sneaky. It's just being, it's focusing it in a different way. All right. And I have we have a really good discussion in this book on pain and all the issues associated with pain and opiate medications and things like that. So if you're really struggling with pain, I would really recommend this book, IC 101. I think you'll find it very helpful. And I wrote that section on pain. All righty, step 3. So what are we going to do in step 3? Cystoscopy with hydrodistension. Hydrodistension should always be low pressure, short duration, and Hunter's lesion therapy. So if you have active lesions, we want to make sure the lesions get treated correctly. Lesions will not respond to Elmeron. Lesions will not respond to bladder therapies like rescue installations. Lesions require lesion-specific therapies. And those therapies are fulguration or laser therapy, steroid injection into the center of the lesion, or Lyris. And I haven't added hyperbaric oxygen therapy. We have research that now shows that's helpful too. And I know you guys, I think on YouTube, all the writing is reversed and you can't read what I'm doing. I'm sorry. YouTube reverses the screen, whereas Facebook doesn't. It's really weird. Okay. Whoops, hold on. We did that one already. Wait. What did I do? Okay. So again, Hunter solution therapy. Step 4 is going to be neuromodulation. That includes urgent PC, which is the ankle stim, which is not particularly invasive, as compared to interstim, which is a surgical neuromodulation. Interstim, they both have exactly the same approval by the FDA. They've been found to be helpful, particularly for incontinence and frequency urgency. They are not specifically approved for IC, and there are issues associated, especially with interstim. There are thousands of adverse event reports with interstim, lots of deep tissue MRSA infections with interstim over the years. But most importantly, it's remarkably expensive. If you are considering interstim, the most important thing you need to do is you need to get in writing from your insurance company that it is covered. Because if it is not covered, you're going to be hit with an $80,000 to $100,000 bill. And that happened to a nurse with IC who she did her due diligence. She asked the billing person at her urologist and said, "Is this covered by my insurance?" They said yes, and no written pre-authorization is required. Then she called the hospital that she happened to work at, that she also had the procedure at. She talked to their billing office. They confirmed, yes, this is covered. No written pre-authorization is required. Then she even called the health insurance company. And she said, "I just want to verify, is this covered by my insurance?" And they said, yes, no written pre-authorization is required. Guess what? A week after she had the surgery, she got a bill for $80,000 and a threat to garnish her wages at the hospital she worked at. So you have to get it in writing. The other thing here is in step 4 is Botox. The challenge. So what does Botox do? Botox quiets and silences nerves. Botox used to be in step 5 because, when they do Botox injection in the bladder wall, that's just kind of random. They just kind of poke it around. And if they accidentally silence a nerve that controls your ability to pee, guess what? You won't be able to pee. You may not be able to pee for weeks or a couple months. So the FDA says nobody should be given Botox who is unable to self-catheterize if the treatment puts them into urinary retention. However, what they did find is that a half a dose reduced the risk of that substantially, which is why they moved it from step 5 to step 4. Erica is asking, why isn't step 4 trigger point injections? Because they've never put trigger point injections or a pudendal nerve block in the guidelines as yet. Because back in 2011 and 2014, it just wasn't standard therapy. We'll have to see what they put in the next round of guidelines. All right, step 5 is cyclosporin. Now, cyclosporin, some doctors consider a bit of a miracle drug. Cyclosporin is really good for people who have autoimmune problems. So it is the most effective at kind of suppressing the immune system. The challenge with cyclosporin is that it does make you more vulnerable to other illnesses. And right now with COVID, it's challenging. That said, I will tell you the story of a friend of mine, a good IC patient that I've known for years, who's a friend, who had very, very severe IC. She was working as a high school teacher. She would self-catheterize at work. And she'd give her bladder installation treatments at work. Really high pain level, but she loved teaching. I don't know how she did it. Honestly, I don't know how she did it. I don't think I could have done what she did. She did every single day so that she could teach in high school. And then finally, one day, a doctor said, I think we need to try cyclosporin. And it's been a miracle. Like she doesn't have to self-catheterize or she doesn't have to do installations anymore. Her pain med, I don't even think she's using pain meds anymore. It has been an absolute miracle for her. The challenge with cyclosporin is it has a lot of potential side effects, and one of the chief side effects is it can raise your blood pressure, and that's eventually, I think, about a year into it, that's what it did for her. She started, I think, if I remember correctly, she started getting some really bad headaches that they associated with higher blood pressure, and she ended up in the hospital, and they had to reduce some doses or something. But she's still using it today, and she's quite happy with it, and she's a new woman just because of this. So this is what they will often try in patients who are just unresponsive to therapies. It's a viable option. The treatments that are no longer done are going to be long-term antibiotics, because again, our urine cultures are generally negative. We're no longer going to do BCG or RTX. Those are old bladder installations that were found to fail at the treatment of IC. Silver nitrate or chlorpactin, which we call the old bladder strippers from the 50s, 60s. We don't do these anymore. They're not even mentioned. It's treatment options, as well as high pressure, long duration hydrodistensions. Those are specifically not suggested and discouraged for use by the AUA in their guidelines. All right. So again, the steps are arranged with risk to adverse events. Now listen. Oh, and step 6 is surgery, obviously, but this is really rare, really, really rare. But now here's the deal here, guys. I want to tell you the story of one of my clients who's in New York, and Nancy says, is the video stopping for some people? It might be. Let me look at the Facebook settings. Well, I'm not getting any errors, so it might be a connection with your issue too. Okay, so here's the deal. I want to tell you the story. Let's just say her name is Mary. That's not her name, but let's just say it is. So she called me about 15 years ago, 15 years ago, newly diagnosed with IC, absolute wreck. And I spent a lot of time with her on the phone, which is what we do, I mean, I'm a support group leader. That's what I do. And some of you need more time. And I will never forget her because she had a very distinctive voice and she was terrified. So I spent probably 2 hours talking with her. We'd go through all the options. And I spent a lot of time with her on diet, because diet is important. If you've got Hunner's lesions or you've got estrogen atrophy or whatever, that's a problem. That's a problem. So anyway, yeah, and then she happened to be like 20 minutes from Dr. Moldwin. So I sent her to Dr. Moldwin for, to confirm her diagnosis. And I didn't hear from her for about 5 years. And then one day she called and she was just hysterical. I mean, she's just hysterical on the phone. Jill, nothing's working. I'm in so much pain. Please help me. Nobody can help me. It's like, all right, hold on. Let's take a step back here for a moment. I need you to take a couple deep breaths. Now tell me what's happening. And she starts describing her symptoms. And they were very clear bladder wall symptoms. Up at night, up all night, peeing every 10 to 15 minutes. And I said to her, it really sounds like, your bladder wall is really irritated. Are you following the diet? And she said, yes. She's like, yes, I am. Don't insult me. Yes, I am. Well, her husband was on the phone. And he goes, oh, no, she doesn't follow the diet. She drinks a pot of coffee in the morning, followed by a 6-pack of Diet Coke every single day. Every single day. And you should have heard her. She started wailing on the phone, just wailing. Like, that's right. Take away everything I love. If I can't have my coffee, if I can't have my soda, I have no reason to live. right? And she's just wailing on the phone. She's furious with her husband. She's furious with me. She's finally been called out. And I said to her, I said, now, how much money have you put into your IC therapies in the last 5 years? She goes, about $20,000. She even had, I think she even had InterStim done. And I said to her, I said, do you realize you've sabotaged every single one of those therapies? You've sabotaged them. They had no chance to work for you. And she goes, what? What? I said, listen, no therapy can counteract the damage done by a pot of coffee and a six-pack of Diet Coke. There's no therapy that can handle that massive acid load. Everything you did was for naught because you were drinking all that. And she goes, what? Oh my God. And I said to her, I said, now I know we talked about diet. Didn't you believe me? And she goes, no. I said, and I know you went to Rob Moldren and he talked to you about diet, right? She goes, yeah. I said, didn't you believe him? She goes, no. Every doctor she saw told her about diet. She didn't believe any of them. And she said to me, she said, well, it never applied to me. And my answer back was, that's because you're an addict. You're addicted. You're addicted to caffeine. And she very quietly said, you're right. You're right. And so the step one interventions, which is water intake, having a good, healthy water intake, doing the diet modification, etc., is the foundation for which all of your successes are built. And if you are not following the diet and doing what she was doing, she had no chance of ever getting better. No wonder she was sobbing in pain. She was by far, she wasn't the worst. She was the second worst patient I've ever talked with who was sabotaging her bladder health with her food. And so, I got her to the point where she wasn't wailing anymore and we were having a discussion. And I said, listen, what do you have to lose? For God's sake, woman, you've got a bleeding bladder and you're pouring acid on it all day. You have to stop. I said, you're going to have to go off gradually because you're massively addicted to caffeine. She said, right. Okay. She called me back 3 months later. She was a new woman. She goes, oh my God, Jill, you're not going to believe it. I'm like, what? I'm better. I'm massively better now that I've stopped the coffee and the soda. Yes, my guess is she was IC subtype 2, bladder wall driven estrogen atrophy. Once she stopped bathing her bladder in acid, guess what? Her bladder actually had a chance to heal. Now, I want to tell you about the worst patient I've ever talked to. A husband called, said, my wife has been diagnosed with IC and we don't know what to do. And I said, well, put her on the phone. I'd love to talk to her. He goes, she won't talk to you. She won't talk to anybody. She's in her bedroom. I said, okay, well, let me talk to you. So again, we're going through the whole thing. Spent a lot of time talking about treatment, spent a lot of time talking about the diet. And he goes, well, that's going to be a problem because she loves her soda. She might have even been drinking Mountain Dew, something like that. And I went, well, it is what it is. You need to tell her, hey, if you had a wound on your hand, would you pour acid on it? The answer is no, of course not. Well, that's what she's doing to her bladder. So he calls me back. He's like not confident, not optimistic. So he calls me back 3-4 months later and he goes, she won't do anything. She won't do anything to get better. She laid in her bed, she took her pain meds, and she drank her soda all day long. I said, put her on the phone. He goes, she won't talk to you. I said, I don't care. Take the phone to her. Let me talk to her. So he walks the phone into the bedroom. And I introduce myself and I say, hon, sounds like you're not doing well. And have a little discussion with her. And I said, now listen, you will never heal if you're drinking soda every day. And you know what she said to me? She said, I don't care. I just want my pain meds and I want my soda. I don't want anything else. I was stunned. And it was one of the rare times, I mean, it's really rare. If you've ever talked to me on the phone, it's rare that I ever lose my temper, ever. And what I ended up saying to her was, think about what you're doing to your children. You are not able to be a mother to your children because you are hooked on soda and pain meds. And I let her have it. I let her have it. I mean, like, how dare you do this to your children and her husband? And heartbreaking, heartbreaking, absolutely heartbreaking. And I mean, I gave them everything I could, and I gave them the doctors and everything I could, and she just didn't believe anybody. She truly, and it's really rare. You guys, I chaired the California Pain Conference years ago. I mean, I was part of the team that got our California governor to sign the Pain Patients Bill of Rights. I've testified on pain care in California. Okay, I know pain care. And what the research shows is that it's very rare that a chronic pain patient ever becomes an addict, because we're not taking pain medications to escape life. We're taking pain medicines to function so that we can do the things we need to do. An addict is taking pain medications because they don't care. She was an addict. Absolutely was an addict. But for the vast majority of patients, myself included, who's had every now and then needed to use a little bit of a pain medicine, we're not taking it to get high. We're not taking it to escape life. We're taking it so we can freaking sleep, so we can get up in the morning and do what we need to do. We're taking it so we can go to work. We're taking it whatever. And that's an important thing to distinguish. Is an addict takes pain meds to escape life. And only once in my life, in 28 years as a support group leader, have I ever encountered an IC patient who was a true addict, and that was her. Now, some people develop tolerance, and that's a completely different thing. All tolerance means is that your body, your liver, has gotten very used to breaking it down. Because that's what happens. Whenever you introduce a new drug or a new chemical into your body, your liver has the sole job of breaking it down. It's like going, all right, what the hell is this? What do I need to do to get rid of it in the body? And what happens is every subsequent time you use that medicine, your liver gets better and better at breaking it down. And that's why you might need more, because your liver has just gotten so good. And so dependence or tolerance is not addiction. And that's why doses sometimes increase. And then, of course, we have dependence also. And with dependence, it means that your body is now accustomed to it. It's accustomed to having it. It's gotten used to it. And so when you go off the medication, your body's going, oh, wait, not so fast here. You've been giving this to me for a while. I'm used to this. And I mean, that's a very amateurish way of thinking about it. For those patients, you've got to gradually diminish. It's just like trying to get off of caffeine or trying to stop smoking. If you stop it, you're going to have a migraine head. You're going to have a headache for a couple of weeks. But if you slowly titrate down, it gets better and better and better. So anyway, if you need support for your pain, again, one of the best things that you can do is go print out those AUA guidelines, because they say pain needs to be addressed at every single appointment. That if we allow this patient to be in pain for a long period of time, more things are going to get involved. We know that the nerves get involved, then farther nerves get involved, then the spinal cord gets involved. But one of the mistakes that pain patients make, and this for any pain patient make, is you wait too long. You wait too long. You wait until the pain is out of control and you're crying before you use it. Fighting pain is like fighting a fire. If you got a fire in your little wastebasket in your bedroom, you pour a glass of water on it, it's fine. But if you allow that fire to spread to your drapes and then to your walls and then to your roof, it's going to take a hell of a lot of water to turn it off. Pain is the same way. Your goal is to try to catch your pain, to catch your IC flares as early as possible and as directly as possible. And so you don't wait until you're bawling your eyes out. If you have that little bit of whatever your doctor's given you, try to catch it early. And I can talk about that a little bit more. Hold on. So here on YouTube, we have an IC patient who says they were prescribed Percocet for the IC and that you did become addicted. Well, it stresses me out because I know it's not good for me. Well, again, if you were taking your pain meds to escape responsibility, yeah, you were addicted. But if you were taking your pain meds so that you can function, it wasn't necessarily addiction. It might have been tolerance or dependence instead. But everybody has their own balance levels, right? Everybody has their own levels, what works for them. Nobody can tell you guys when you need to pee. Only you know when you need to pee. You're the one living in this body, right? All right, let me go to Facebook here. Barbara tried all other options for years. Cyclosporin worked from the first dose. Blood pressure is higher than that before you've been on it for 4 years. Barbara, that's fantastic. Absolutely fantastic. Thank you for sharing. Absolutely. Thank you for sharing your story. Judy says, are glomerations the same as Hunner's lesions? The answer is no. Absolutely not. They are not the same, and I've got pictures. So let's look at this. A Hunner's lesion is a big bloody spot. So let's look at this one right here. So Hunner's lesions usually have a center, and then it has arms radiating from the center. See, this one has arms radiating it, but not all the way around. It kind of gets a little fuzzy, right? Can you see that? Can you see that? The center with the arms radiating about it. So when they biopsy a lesion, it is filled with inflammation. Filled with inflammation. There is a biological war happening in these lesions. Inflammation means that your body is fighting something. It's your self-defense mechanism. If you have a mosquito bite, the area becomes inflamed as your body senses the poison from the mosquito. It mobilizes white blood cells to the area to fight, right? So these patients have massive inflammation in their bladder wall. And now we have a clue as to what they could be fighting because we now have the research showing viral infection. These are petechial hemorrhages. Okay, so you can see flat out, very, very different. Now, in the old days, this was considered the gold standard diagnosis of IC, that if they did a hydrodistension and they found these red spots on your bladder, that was considered a de facto, this person has IC. But when that came out in 1987, which was the National Institutes of Health diagnostic criteria for IC research studies, another researcher went not so fast. They did a research study of a significant number of women who were going to have tubal ligations, no bladder symptoms at all, no bladder symptoms at all. And they said, can we do a hydrodistension and look at your bladders? And what do you think happened? Bam. This now is considered meaningless. It's considered meaningless, that it is in fact probably a residue of stretching the bladder. That when you stretch tissue, like if you were to stretch your bladder, I mean your stomach, and it gets bigger and bigger and bigger and bigger, eventually it's going to go past the point of normal stretch and tissues are going to start to break. So the finding of petechial hemorrhaging or glomerations on the bladder wall is no longer meaningful. And in fact, it was at last year's AUA meeting, I think, that Phil Hanno confirmed that. Dr. Phil Hanno, the chairman of the committee that created the IC guidelines. Okay, so glomerations are absolute. Oh, and then of course, the other thing is when you biopsy these, there's no inflammation. There's none. When you biopsy lesions, massive inflammation. When you biopsy these, it's not the same. Hunter's lesions, you can see the bladder wall breaking down over the lesions. Not so much here. These are just, again, kind of probably just wounds from the procedure. Let me show you, I want to show you one of my mystery images. I want you to look at this. Look at this. Look at that. You know what that is? That is a bladder stone growing out of somebody's bladder wall. Huge one, but look, smaller one, smaller one, smaller one. Bladder stones are, I don't want to say common, but they happen in areas of severe injury where the calcium pathway gets disrupted. And instead of the body reabsorbing whatever that mineral is, what happens instead is you get these stones that merge out of the bladder wall. And then because they're stones, they're very painful. You can see all the sharp edges, right? Look at all those edges. These are no fun. And if they're big, they'll block your urethra. Now, this is not common in IC at all. I've only worked with one patient in 28 years who had these, and he was not an IC patient. He was that same surgical injury patient. So he got bladder stones after he'd had multiple surgeries, and because they were trying to repair damage and figure out what was driving it. I mean, again, he was a surgical injury patient. The second to the last surgery, they accidentally left a bleeder in his bladder, and his bladder filled up with blood clots. And it became an emergency, and he had to rush back to the hospital. And they took him into the operating room, and literally as they were opening him up, his bladder split in two, and all the blood clots came out. And they had to sew him back up, and the bladder stones came up around the area they sewed up because that injury was so profound, it damaged the calcium pathway, something. But guys, again, that's just kind of an interesting bladder story. It has nothing to do with IC. Nothing to do with IC. You don't need to worry about that. I like weird stories like that. Nancy says, I sent you an email asking about possible reactions to the COVID vaccine. Could you please let me know if there have been? So Nancy, hold on a sec. Let me just write this down. You guys give me homework, let me tell you. Hold on. Vaccine reactions. All right. I will try to do that, Nancy. Jean says, I was just wondering, what is your opinion on fulguration for people who may have a biofilm bacteria in their bladder? There is a doctor in Turkey. Well, fulguration only applies to Hunter's lesions. I mean, if this is somebody who's saying that the best way to get rid of a bacterial biofilm is to fulgurate your entire bladder, there's a problem because that leaves scar tissue behind. And if you get your whole bladder fulgurated or lasered, your bladder is going to lose its ability to stretch and to expand and contract. and all of a sudden you're going to have much lower bladder capacity. I don't know anybody who's ever suggested that for IC in any of the reading I've done. Laura says, are the classifications of IC also on the AUA site? No, they're not. The American Urology Association has not endorsed any specific subtyping mechanism, with the exception of an article that Phil Hanno released a couple months ago, where they are willing to say that there are bladder-centric patients and beyond bladder-centric patients. And so they were saying at a minimum, we shouldn't mix the two. We shouldn't mix the two in research studies. And that's actually the topic of my editorial in our summer magazine that's just coming out. And the editorial is a key flaw in IC studies. And it's real short. Why don't let me just read it to you really quick. Could a research study testing a new treatment for Hunner's lesions be successful if it also included patients who had pelvic floor muscle injury? Patients with Hunner's lesion disease have visible wounds on their bladder wall that are known to bleed profusely. In contrast, patients with pelvic floor dysfunction may have a perfectly normal bladder. They struggle with muscles so tight the blood flow to the bladder is hampered. So should they be included in the same research study? The answer, of course, is no. In 2011, Dr. Phil Hanno admitted to a packed house of urologists at the annual AUA meeting that the more than $100 million invested in IC research had failed to produce any new therapies. Just a few weeks ago, he and his fellow researchers released a new paper which addresses this fundamental flaw. They said, quote, because of the heterogeneous nature of this disease and its multifactorial etiology, clinical trials in all-inclusive populations of IC-BPS patients without phenotyping in the last decade have mainly failed to discover new therapeutic modalities. Okay, yes, that's very academic. So yes, that's right, folks. We can't put apples, oranges, grapes, and bananas in the same study and expect results. Would Receptor, a once promising therapy developed by Equinox Pharmaceuticals, have been successful if it had only targeted a specific subset of IC patients? We'll never know. Their final study was deemed a failure. Millions of dollars were lost and their research staff were let go. How many other potential therapies were deemed failures because they included different types of patients in the same study? Dr. Hanno and colleagues believe that patients should at least be divided into two unique groups, bladder-centric and bladder-beyond pathologies. Certainly, a patient with visible bladder wall damage should be placed in a separate group than patients with a normal bladder wall. This is a step in the right direction. With now greater understanding and support for the many subsets found in the IC patient population, new research studies will be more effective provided that they select their patients more carefully. And wouldn't it be interesting if they revisited some of the older therapies that were deemed failures to see if they too might be helpful for some IC patients? We cannot afford to lose another decade of research to fundamentally flawed clinical trials. All right, so that's my editorial for our summer magazine. Erica says, your tailbone won't budge after 8 months of physical therapy. It's dislocated to the left. You're going to Beaumont because I don't know what else to do. Anything else I can do between now and the end of October? Well, so, Dr. Peters, again, is, in my opinion, a master diagnostician. And so what I would do if I were in your shoes is I would start making a concise list of your symptoms. Especially the weird symptoms. The devil is in the details here. Sometimes it's that little symptom that only happens once in a blue moon that will absolutely confirm your diagnosis. And so I would want to know, number one, where is your pain located? Is it centered or is it to the left or right of center? Do you have pain? Do you have sciatica? Do you have pain that's being referred anywhere? Is it being referred to your lower back? Is it being referred down a leg? Again, any sciatica. Do you have any pins and needles when you sit down? Are there pins and needles? Do you ever feel like you're sitting on a cell phone on vibrate? When is your pain the worst? Before you pee or after you're done peeing? What makes your pain better? What makes your pain worse? Right? So, for example, if heat feels great, use it because heat relaxes muscle. But if your body hates heat and loves ice, then that tells us that nerves are probably involved. And so, you know, you you want to try to differentiate between your bladder symptoms and your other beyond bladder symptoms. And if you want to call me before your appointment, and we can come up with a list of questions for you. Happy to do it. Happy to do it with you. Jean says, "Sorry, it's not just for IC patients, it's for anyone but with bacteria behind the wall. I didn't realize fulguration caused scar tissue." Yeah, fulguration, laser therapy leaves a trail of scar tissue behind. And you're kind of falling into this extremely controversial, you know, group of people who are telling IC patients you all have bacterial infections in biofilms in your deep in your bladder wall. And guys, this argument has been around from the old internet news groups day, back before Facebook, back when we were just starting to build websites. Where IC patients got together were in the old internet news groups. And let me tell you, you want to talk the worst of the worst in terms of discussions. It was in the internet news groups because people had fake names and they could say whatever they want and they were bloody mean. And so there was a very vocal group of patients who very, very aggressively told everybody else, "You're idiots. You all have infection." And yet the challenge here is that the research simply never supported it. And so we have had now for 25 years a very small but vocal group of patients and a couple of doctors, not in the IC world, but a couple of doctors who continue to insist over and over and over that there's no such thing as IC, that you all have a chronic bacterial infection. Well, the flaw with that thinking is most of them don't believe that urine tests are meaningful. They believe that urine tests miss them. And they just aggressively throw antibiotics for a long period of time at these patients. And that's one of the reasons why we have such dangerous antibiotic resistant infections now, is because of the overuse of antibiotics. Every hospital and every care provider, at least here in the United States, they're required to have an antibiotic stewardship program. They're required to make sure that antibiotics are not overly prescribed because of the dangers they pose. As an example, Cipro. Cipro was very popular for UTI 15 years ago, 10 years ago. Cipro is now associated with aortic aneurysm. And not only bad tendon problems, but aortic aneurysm. One of our top IC patients, who's an author, has an aortic aneurysm from taking Cipro for a long period of time for their quote unquote IC, quote unquote mysterious bacterial infection. Cipro now, according to the latest FDA ruling, is not to be used for simple UTI. It is only to be used for complex infections uh, because they say the risks outweigh the benefits. Cipro is dangerous. It is dangerous. The other thing that we really have to really clearly understand is we now have something called next generation DNA urine testing. And what that allows us to do is it allows doctors to look at everything living in your bladder, because your bladder is not sterile. That was what they thought 10 years ago before the Biome Project and this new technology got in the way. Everybody thought that the bladder was a sterile organ just back in the day, when people thought the stomach was a sterile organ because of all the acid in it. And of course, now we know that stomach ulcers can be caused by Helicobacter pylori, that there are some bacteria that live very, very happily in the stomach. Well, there are also bacteria that live very happily in the bladder, and they're meant to be there. They're good bacteria. There's one specific bacteria in the bowel, as an example, that is the only source of the food that the cells lining the bowel eat. The human body does not make that food. That food comes from a specific species of bacteria. And if you kill that bacteria, you're killing the outer surface of the cells in the bowel. And you have to wonder what role that plays in all, Crohn's disease, all these terrible bowel conditions that are happening right now. So we don't yet know what the good bacteria do in the bladder, although I think we can make an assumption that at least one species is probably feeding the cells in the bladder. And so we have good bacteria in the bladder. And then there is the potential for pathogenic bacteria in the bladder. That is true. That is absolutely true. It is possible. UTIs happen all the time, especially if you are older, if you're an older woman postmenopausal. Okay, that's common. But here's the deal. Your bladder, your urinary tract can also have fungus in it, and it can also have virus in it. And it was our own US National Institutes of Health who discovered and proved that some of you have candida infections in your urinary tract when you are flaring. If you flare when you eat sugar, if you flare when you eat carbs, we have to review the role of fungus in your urine. And you can find that article on our website with the direct links to the research from the MAP Research Network. So candida infections are absolutely possible. But guess what? So are viral infections. And again, it was the Europeans who made that discovery, I think now 6-7 years ago. They were the ones who found the polyoma virus in the urine of patients with IC, along with other potential viral infections. And again, very, very strangely, like we're reading all this research from Europe going, oh my God, this is exciting because maybe we can treat this viral infection. And our US National Institutes of Health they said nothing about it for like literally 5 years. What we didn't know is that they were doing their own viral study that was released last year, which confirmed it, that some of you have polyoma infections in your bladder wall. Like 5 to 10%, maybe 5%. It was a small population, but they found it too. So for anybody to suggest that every IC patient has chronic bacteria, they're just not paying attention to the science. Because chronic fungal infections can happen, chronic viral infections can happen. Polyoma absolutely associated with hemorrhagic cystitis. Hunner's lesions happen to hemorrhage. So hello, it's not that big of a stretch to go, oh, maybe Hunner's lesion patients have the polyoma virus. And now we have research studies that are confirming that for some of you, it could be happening. So this is where something called next generation DNA urine testing is really meaningful. And I have I've had it done twice so far. So this is what all the infectious disease specialists are using. These are the tests that are being used to identify COVID. Next generation testing, where they're studying the DNA they find to identify it. So when you have a next generation test, it's a tiny amount of urine. I mean, it's like this big, this little tiny container of urine. And they normally have you pee into a container 3 times a day, shake it up, extract a little bit of it, put it in this little container, and then you send it off to whatever company you're going to use. And what they do is they isolate the DNA that they find in that urine, and then they identify it. What is this from? And it's the next generation DNA urine tests that have played a huge role in identifying candida infections to some of you, because you've got all the symptoms of UTI. Man, you're bawling your eyes out. It hurts like hell. You're up all night peeing. You go leave your urine. They call you back. There's nothing here. And yet you've got fever. You've got all the symptoms. You got chills. You feel like you have infection. The problem with a typical urinalysis is they only look for bacteria. They don't look for fungus. They don't look for fungus. That's why a next generation test is so powerful. And last year, Dr. Curtis Nickel, the top IC researcher in Canada, gave a speech at the AUA in which he said Next generation DNA urine testing will replace urinalysis sooner rather than later because it is so much better. But there are two problems with it. Problem number one is that doctors, they just don't know about it, and or their health insurance won't pay for it. So, like, I wanted to have it done because I was having these weird symptoms down below, and I thought it was a weird fungal infection. And my gynecologist absolutely refused. She's like, "No, I don't want to do that." I said, "Listen, I'm paying for it. I just need your signature on the form. I just want to know. Can you just tell me? I just want to know, is there anything else in there that we should know? I've been in pain for 3 months." And eventually I got her to sign the form and look at the data. So look, here's the data. So I had a microgen test, and it was this is my data for a vulvar swab, because I started developing pinpricks on my vulva, and they all thought it was yeast, but it didn't get better, even with yeast meds. And then they thought it was eczema, it didn't get better. And we know in hindsight, it was nothing to do with the skin. It was pudendal neuralgia. My muscles had just gotten very tight and were squeezing the nerve. But part of my due diligence was to have a next generation test. I wanted to know, is there anything weird going on there? And it's just data. It's just meaningful data here. And so I had a microgen test. Microgen's one of the companies there's a couple of companies that do it. Let me make sure there's nothing personally identifying here. So one of the first things that they look for, do you have any weird resistance genes? And you can see in red right there. I don't know, Facebook, you can see that. I have a drug resistance gene, and I'm resistant to aminoglycosides. That's a type of antibiotic that I have never taken. I've never taken that antibiotic unless somebody gave me a shot while I was having surgery. Never taken that medicine, which means that I got that drug resistant gene from food, from beef or chicken, right? So that's interesting. Do you have any drug resistance genes? So what did they find? So this is what they found in my vaginal swab. They found lactobacillus, which is a normal flora. They found Prevotella bivia, fairly normal. They found Streptococcus, nothing, 2%, and Gardnerella, but not in any measurable quantity. And so, and then the other thing that they do, and so the fungus, there was no fungus found. So here's the fungal thing. So no fungus was found. So that completely ruled out the candida theory. So it's like, okay, we're not gonna do the candida, and then the candida treatments anymore. And then they will tell you what antibiotic is the most successful at killing that specific species. So there are, at the World Health Organization, as well as the Center for Disease Control, these giant databases of just DNA for all these subspecies, these species and subspecies, et cetera, et cetera. And that's what they use to try to figure out what could be infecting you. So I'm a fan of next generation testing. I like data. And this was important for me at the time because we knew at this point in time, there's no reason for me to be doing any antifungal stuff like I'd been doing for 2 months, right? That it was, and it turned out, again, it had nothing to do with my skin. It had everything to do with the fact that my muscles had gotten tight and they were squeezing my pudendal nerve that was causing the pins and needles I was feeling. I have a website, bladderhealth.org, that I built a couple years ago that you can go and watch a couple of videos of doctors that use microgen. We work with microgen on occasion. So I have a relationship with that company. Zelda is asking, I wonder if good bacteria can grow back after years of Cipro. You know, that is ultimately the critical question here is, We have to understand that the biome of 2021 is so grossly changed from the use of antibiotics in the last 80 years that none of us have the original healthy biome, because we've all been exposed to antibiotics at some point in time. The only people that have a normal biome are going to be indigenous peoples, maybe down in Brazil, in the Amazon, or in Africa, where they have no modern stuff, and so they have done a little bit of research with that. Obviously, you can't go into a group of indigenous people who barely speak English and say, "Hey, can we take your blood and urine for research?" That's a very, very delicate thing for them to do, but they have been able to do some of that. Um, Will we ever have that original biome back? No, we won't. It's forever changed because of everything we've been exposed to, combined also with our food. Our modern day food, is not healthy. The vast majority of manufactured food is just not particularly healthy. And so we don't know how that's changed our biome either. So the closest thing we have is using probiotics, where you are introducing beneficial bacteria after you've used antibiotics, or maybe while you're using antibiotics. And uh, it's a bit of a guess in the sense that, we're still trying to understand the urinary biome. We're still trying to understand everything that lives in there and what it's meant to do. But we certainly know that doctors have for years been telling patients to take probiotics. The probiotic that so I use on occasion, I don't take probiotics every day. I eat yogurt every day. I try to eat live cultures a couple of times a week for sure. And something that is fairly benign. I really like unflavored. I do coconut milk yogurt. I'll do blueberry, peach, or unflavored. Um, and so that's where I try to get my bacteria. Because ultimately, the beneficial bacteria actually begins with mother's milk. There was this great food study, fascinating food study. Somebody was trying to define what's the best food we could ever eat. And they first went back to, what is mother's milk made of? And what that research study found was that there's nothing in mother's milk that nourishes the human body. Nothing. What's in mother's milk is food that nourishes the biome. It's food that introduces and nourishes that important population of beneficial bacteria in the bowels of the infant. And that was absolutely fascinating. I think that was a documentary called Food Inc., something like that. So anyway, there you go. And that's, of course, why we don't want to be eating proteins that have been massively treated with antibiotics. Number one, we got the risk of drug-resistant infection. And number two, it's changed because of all the antibiotic exposure. Erica says, what do we know about Ehlers-Danlos syndrome and IC? My local urogyn is sending me to an EDS specialist to look at the spectrum of EDS, specifically fascia tightness versus the hypermobility you usually hear about with EDS. I don't think we have any meaningful studies that have been done on that. Hold on a sec. Let me just do a quick dive. We need to do an article on that. I've often wondered if I could have a variation of that. 'Cause I have an issue with the ligaments by my SI joint, but I'm also really dealing with TMJ and ligaments on my left side that are kind of stretching out. Ligaments or fascia or whatever. Yeah, there's not a single research study that's ever been published on IC and EDS. Hey, do me a favor, hon. Erica, would you please reach out to me? I would love to hear what the EDS specialist has to say, because that information could really help other patients too. So you guys, for anybody out there, you can all email me. My email address is icnetwork@mac.com. That's short for Macintosh computer. So it's mac.com. Eric, I would love to hear from you. And also too, by the way, we had a doctor hey, if anybody knows Paige Owen Horn on Facebook, she was in our last support group meeting. She's a retired doctor. And and she asked me a question after I shut down the meeting and I couldn't go back and we're not friends. So I sent her a friend request, but I haven't heard from her. If anybody knows Paige Owen Horn, could you do me a favor? Pop her a message and let her know that I'd like to talk to her. I always hate it. I'm shutting things down and then somebody asks a really good question. And I've literally shut it down and I can't answer it after it's shut down. Christy says, I finally found a doctor to order the test you suggested. I just had a bladder installation on Thursday, which usually helps, but this time it didn't help. I hope it's not another infection. Well, it'll be fascinating to see what they find, hun. It'll be really, really fascinating. Again, it's data. And I just, I had somebody, listen, Dr. Dan Burkoff said to me, he said, our top pain specialist for IC, who unfortunately has now passed away, he said to me, Jill, if you haven't pissed off one person a day, you're not working hard enough. And the discussion of next generation testing pisses off a few people. And to me, it's just data. It's potentially useful data. If mine had come back positive for fungus, we would have confirmed that I had a weird candida infection. The fact that it ruled out fungal infection completely changed the way we treated my issue. And so it's useful data. But it's tricky and it's difficult to interpret. So it is what it is. Zelda says, what do you think about a probiotic vaginal cream? I know that there are more creams that are trying to take a probiotic approach to it, just like Bladder Builder adds beneficial bacteria into that formula. I don't have any experience with it myself. The challenge with vaginal creams is that they tend to have a lot of preservatives in it that can be irritating. So some people have put just directly put yogurt in their vagina to just try to populate the vagina in the easiest way possible. And I think that, here, let me look at this. This book, The Vagina Bible by Dr. Jen Gunter, one of my all-time favorite books. So good. I'm pretty sure that here we go. Yogurt, page 390 to 391. Let's see what she says about that. Yogurt for yeast infections. Yogurt doesn't contain the strains of lactobacilli that are important for vaginal health. When a woman puts yogurt in her vagina, she's putting other bacteria in there, as yogurt has live cultures, and the consequences are unknown. It may feel soothing because it is cream-like, but the risks are unknown and it will be ineffective. Oh my God. Oh, look at this. This is a list of old, this is hysterical. This is hysterical. So chapter 47, a journal of old wives' tales. Here's a list of some of the old wives' tales, although some are not so old. Apple cider vinegar to balance your vaginal pH. Vinegar has approximately the same pH as stomach acid, so how a shot of vinegar could balance your pH, but the acid floating around in your stomach doesn't, is never explained. Okay. Second, old wives' tale of birth control causes weight gain. This answer has been well studied and is no. This is, let's see, anyway, coffee enemas for anything. She goes, dear God, no. People, even some doctors promote this to treat depression. I just can't even. First of all, this is a waste of good coffee. Medically speaking, to believe coffee in your rectum could treat anything is ludicrous. I mean, why doesn't drinking coffee have the same effect? Okay. Here's another one, drinking 8 glasses of water a day. Many doctors have tried and valiantly failed to kill this myth. It originated in the 1950s. And anyway, she says what to do. Essential oils for anything. She says she's not for essential oils. Fancy water like alkaline water, which I don't support, is just ridiculous. Garlic for yeast infections, garlic in the vagina. She goes, no. uh, oh my God. Jade eggs for your yoni. The idea is if you put an egg-shaped jade rock in your vagina, it puts you in tune with your feminine energy or something. Yeah. It's kava, lifting your arms over your head while pregnant will cause the cord to wrap around your baby's neck. Nope. Magnets for hot flashes. Nope. Onion applied to warts. No. Parsley in the vagina. No. Imagine putting a sprig of parsley up there. No. She said the sprig stuffed up the vagina every night, 3 to 4 nights to induce a period. Look, I don't make this stuff up. I just report it. Apparently, some people who are wrong, think it could stimulate uterine contractions. There's no evidence that the vaginal application of parsley can do this to the uterus. Steaming the vagina. This is promoted to cleanse the uterus. This ties into a destructive myth that the uterus is unclean or that a period is cleaning the uterus. Anyway, guys, urine smell indicates a bladder infection. No, I'm not sure how this started, but strong smelling urine does not indicate anything bladder health wise. There are some medical conditions that can change how urine smells, but a bladder infection is not one of them. So anyway, you guys, awesome book, The Vagina Bible by Dr. Jennifer Gunter. Parsley. I mean, like, seriously? Oh gosh, the things. And the challenge here is, listen, you're legitimately in pain. You are legitimately frantic. You want to get better. And the challenge here is that franticness can drive really poor decision making. And I have worked with patients who've done all of that. They have done massive cleanses. They have restricted their diet. You name it, they've done it. And they often will do it all at the same time. And they end up getting much, much sicker because of what they're doing. Angela says, I was reading in your magazine about the possible use of singular to help. I'm going to see my doctor this week and I hope she'll let me try it. Bring her the magazine, show her the data, and see what she has to say. Back when we were talking about pain medicine, there is, I forgot to mention one thing. Remember we were talking about drug dependence, not drug addiction, drug dependence, and that your body gets used to something. Thus, you can't really just stop it overnight. You will have withdrawal. There are a couple more medications that have been known to cause a very, very strong withdrawal. One of them is Lyrica. And Lyrica has been recommended to a lot of IC patients. And the challenge here is that the dosage is so high on the lowest dose that you can't cut it in half and go lower, lower, lower. And so it's called, what is it called? Lyrica discontinuation syndrome. And there are a couple of medications like that cause a discontinuation syndrome where you have to go off gradually. And it's really, really hard to get off. And so, it's very important that when your doctor is suggesting a medication, especially, kind of an off-label pain medication, something like Lyrica, you need to have a heart-to-heart and say, how easy is this to stop? If I don't like it, how easy is it for you to stop? And rather than going directly to the pharmacy and picking it up, it would be important to, get on your phone and go to drugs.com and look at the basics for that and look specifically at withdrawal and or discontinuation so that you are informed. Because we have had a number of patients who have been put on Lyrica and they ended up hallucinating for 6 months trying to get it off. And then there's an over-the-counter allergy med. The FDA did a warning about it last year. I don't remember the name of it. They did exactly the same thing. This really severe, tortured discontinuation syndrome where hallucinations happen. And it's a freaking over-the-counter medicine. Deborah says, I'm constipated due to pain meds. Would stool softener worsen the pain? You know, hon, they have a new medication that can help with that. I don't remember what the name of it, but you can ask your pharmacist, ask your doctor. There's a new medication that was created specifically to help you if you are constipated due to the use of medication. Would a stool softener worsen the pain? I don't know. I don't see how it would, but I mean, I gosh, you're kind of damned if you do, damned if you don't, because you know, when I was working with a patient last week who was kind of going through this, she was really struggling. Yeah, Linzess. Thank you, Laura. Linzess is the medication that they now recommend for people using opiate medications who are struggling with constipation. You know, one of the things that could trigger more pain is you using something like senna, like a senna tea. A senna is a stimulant. So what it does when you take it is it forces your bowel to spasm to try to move things along and to help you pass them. But sometimes those spasms can actually be really painful. So, and the other thing about senna is if you use it every day, then your body becomes used to it, and then you might be suppressing the normal bowel function that would help you have a normal bowel movement. Um, the other thing to understand is that they talk a lot about blockages. And I think that we think, gosh, you must be blocked by a really hard stool, like filling up the colon. But in actuality, it's kind of the opposite. Some blockages are because they're taking too much softener. You have to remember that the bowel is a tube. It's just a long tube, right? It's a tube. And the way that it moves food along is it spasms, right? It just gently pushes down and it squeezes whatever's in your intestine down to your rectum so that you can pass it. And that's called the gastrocolic reflex. And it basically is food in, poop out. That when you eat something, that generally triggers this gentle spasming to move stuff along. And that's why if you try to have a bowel movement before you eat breakfast, you're not letting your body do what it should do, because normally it's the act of eating breakfast and drinking something warm that, I mean, we all know that when you drink coffee, it helps you have a bowel movement. It does it two ways. Number one, it's that warm reflex. And number two, there's that little bit of caffeine stimulant. But it's important that you remember that it's a food in, poop out reflex. So normally you poop after you eat. So generally people have bowel movements after they eat breakfast and or after they eat dinner. I only eat 2 meals a day, so I'm not sure about lunch. Cardis just says, oh, thank you. Arlene says Cymbalta and Effexor. Yes, Cymbalta discontinuation. Thank you. Cymbalta discontinuation syndrome is a beast. It is rough to get off. And the same with Lyrica and the same with Effexor. Gwen is saying that the doctors normally recommend Miralax. To help with opioid-induced constipation. How long should somebody stay on Miralax? I have no idea. You'll have to look at the instructions. Gwen. Oh, Gwen. Gwen. You just reminded me something. So Gwen's answer to that was Miralax forever if needed, but I do half the dose because I have multiple sclerosis. And she says it gives you what the doctors call pudding poop. No cramping, start slow, takes a few days to work. Okay, and that actually reminds me. Thank you, Gwen, because the use of the word pudding reminds me that there's something called power pudding, which is often used in convalescent hospitals, and it's a combination of oatmeal, bran cereal, and applesauce blended up. And you can just Google power pudding, and it's like a tablespoon or two a day, and that's kind of a more natural way also of trying to help that natural urge. I have no shame. Guys, like seriously. Yeah, thank you, Gwen. I'm more than happy to talk about anything here. There's very few things that you can ask me that I am not embarrassed to talk about. Although I shouldn't speak because I have not that you need to know this, but I will tell you that I have this little tiny hemorrhoid that's like 2 inches up my rectum that is right on top of a nerve. Like, holy hell, it is so sensitive. And I've had my doctor at the time was this young hunk. Oh my God, so handsome. He was like 20 years younger than me. Kind of looked like, what do you look like? He looked like an actor, just adorable. And I honestly, I couldn't talk to him about it. Whenever I was having an issue with my hemorrhoid, I did one of the daily appointments and I picked a woman doctor. I was too embarrassed to talk to him about it. And then finally, I just at one appointment, I said, one day I'm going to talk to you about my hemorrhoid. And he goes, Jill, I have ulcerative colitis. If there's anybody that you can talk to about the bowel, it's me. And you'd never know it. He's a sweetest, nicest, most handsome guy ever. And I was just too embarrassed. But then it's like you can't, you just to show that you don't know what somebody's history is. Here, hold on a sec. I just got an alert about something. What the hell was that? Hold on. Fire season. I have to check. We're having fires almost every day now. But hold on. Some sort of alert just went right through. Whoa. And it said Highway 12, and I'm on very close to. Oh, crap. Okay, wait. That's really close. But it's not a fire, it's some sort of police activity. Okay. Wow. Also, they announced this morning that we have the Delta variant in my my local high school and my local middle school. They went back to school last week. And guess what? Now families right in my neighborhood have the Delta variant because they went back to school too soon. Which means now I have to be really careful going to the store because it's in my freaking neighborhood and it infuriates me. Deborah says, I can't believe how amazing you are. What you do is so compassionate and you are so informed. Thank you, hon. Christy says it's everywhere. Yeah, I know, but we hadn't had any. I live in a little valley. Like in Northern California, we're all in valleys. Like my town, Santa Rosa, is in 3 valleys. The Santa Rosa Valley, Bennett Valley, and Rincon Valley. I live in Rincon Valley, and it's the smallest valley. And this is the first time. I mean, a year ago we had some cases, but they were maybe 5 miles away. Now I got cases in my neighborhood, and that is freaking me out because I got an unvaccinated 98-year-old in the house who refuses vaccines. Oh, Christy says you used to live in Clear Lake. Yeah. Yeah, hey, man, they're having a lot of fires up there, girl. They just had a fire, north of Hidden Valley last week. I think they've had 2 fires there in the last 4 days. Diane says gabapentin as well seems to have a bad reputation for discontinuation. Yeah, I think so, but it's not as bad. I mean, these like the Cymbalta discontinuation syndrome is, I mean, we're talking hallucinating. It's terrible, and it lasts a long time, like months and months and months. Like I would never, ever, knowing what we know now about this, I personally, I mean, listen, you compare the risk of that with a risk of a Vicodin once a day that only works for 4 hours, but it turns the pain up, but it's super easy to stop if you're taking a small amount. You know, it's challenging. Christy says Citrasil is a good one to take. Could magnesium help with constipation? Yeah, potentially. You know, but if you do too much, you know, then you're going to have, when I was younger, I had a lot of stomach stuff in school, and I used to, I mean, like literally I was in elementary school with Rolaids in my pocket. That's for another reason I've talked about before. We had a really bad person who was hurting people, and that's why my stomach was so upset. What I didn't know is that the more you take those, the looser your bowel gets, and then Cardsy is saying Kaiser Santa Rosa just stopped allowing visitors due to COVID. I believe it, and I'm a Kaiser member. Gwen said, I was at the dollar store this morning. People were there bringing coughing sick kids to the store with no mask. I was terrified to go anywhere. I live by 2 schools. Like, what the F, people? Seriously, do not send your child to school if they have any symptoms. You should not take that child with you anywhere. You should not be going anywhere because that means it's in your family. It's in your home. 10 days. Gwen says, can Visceral help with pain fast? No, Visceral is not a pain medicine. Visceral is an antihistamine known as hydroxyzine pamoate. And what it does is it reduces the production of mast cells by in the bladder wall. Visceral and hydroxyzine and Atarax are believed to be the most effective at reaching the bladder. And so I took Visceral for 8 years, maybe from like 1990. Probably 1993 to like 2002. And the reason why I stopped is because it finally gave me night terrors. Hydroxyzine is in the AUA guidelines. It's a step 2 treatment option. You know, one of the ways we kind of describe, think about this. Okay, where is it? Where's my picture? All right, what did I do with my glomulation picture? Where is it? One of the ways we used to describe IC years ago is that it was like 1,000 mosquito bites at once in your bladder, or 100 mosquito bites at once in your bladder. Can you imagine how bad that would feel? So anywhere that urine can get deeper into the tissue, it causes the same reaction that a mosquito bite would cause. Urine doesn't belong in that tissue. Your body, oh, here it is. Your body interprets that as a foreign invader. And so what happens, so imagine everywhere you have a spot here, urine is getting deeper into those tissues, potentially. I mean, obviously it's bleeding, which means the tissue is open some way, thus urine can get down into it. And that's causing mast cells to release histamine. And histamine is what makes mosquito bites burn and itch and swell and turn red. So 100 Again, so years ago, we used to say for IC, imagine 100 or 1,000 mosquito bites at once in your bladder, because that's what happens. Mast cells release histamine in these irritated areas. So the use of an antihistamine can calm that histamine response. And that's why antihistamines can be valuable. And then an antidepressant, they're not giving it to you for depression. You should not be offended. Please do not be offended if somebody says, hey, have you tried a little bit of Elavil or amitriptyline? Because that calms nerves down. And you know what? I have a graph. Hold on a sec. I think it's here. I don't know. Is it here? Yeah, here it is. Okay. Now this is going to be hard. I'm going to try to hold this up for you guys. So this is what happens when urine gets where it shouldn't be. So we have a bladder insult. And now so let's just say chemotherapy, or you drinking way too much diet soda, okay? So we have a bladder insult, which then causes epithelial damage to the skin, right? And then because the skin is damaged, we get a leak of urine, including some potassium, into the wound, right? And then what does that do? That then activates nerves. It activates the pain nerve, the C fiber, and it also has the potential of, well, it certainly will also activate the alpha afferent nerve, which will cause more frequency urgency, right? So because the nerves are irritated, they're releasing a substance called substance P. Irritated nerves do bad things. They release irritants. And then what happens is the substance P causes mast cells to release more histamine. And you can see you get in a vicious cycle. The mast cells release histamine, irritates the nerves release substance P, and you get stuck here in this really vicious skin irritation cycle. And it's very hard to get out of this cycle. And so what happens, what they do is they give you an antihistamine like hydroxyzine to turn half of that off. That when you do the antihistamine and you control the mast cells, then we're not at least going to irritate these nerves more. And then they can also do tricyclic therapy, which is the antidepressant, to calm this down. So the whole antihistamine antidepressant is all about breaking up this vicious cycle of irritation in the bladder wall. All right. So anyway, if it runs amok, you're just stuck here over and over and over. God forbid you be drinking coffee every day. Then you're insulting your bladder every day. You're creating more injury. You're allowing urine to get down where it shouldn't go. Then you're triggering nerves and you're triggering mast cells. And so this is the treatment model. I want to try to hold it up, just give you guys an opportunity to see it. Facebook, I have to hold it higher for Facebook. So this is kind of the treatment paradigm that has been used to create the AUA guideline. Let me see if there's one other thing here. Oh, this is really good too. The cycling of pelvic pain. So let's look at this for a moment. Here, hold on. So here you've got an irritated bladder, or maybe an irritated bowel, irritated vulva, etc. And because you're in pain, your muscles are going to get tight and they might start to spasm. Okay. And we all know what those spasms feel like. You can, where literally you're sitting on the toilet and all of a sudden you bend over, it's pain shooting down your legs and up your back. That's a real bad bladder spasm. I found bowel spasms to be even more painful, right? Okay, so we have a pelvic floor spasm. This then causes increased pain, poor urinary flow, urinary hesitancy, constipation, and painful intimacy. Why? Because hello, your muscles are tight, and it's pretty hard to pee and poop if your muscles are tight. Urinating and defecating are all about relaxing things and letting them out. It's pretty hard to do that if your muscles are tight. So if you're straining to have a bowel movement and you're straining to pee, your muscles are too tight. It's that easy. You should be able to sit on the toilet, relax, and pee immediately. If you can't do that, you have a muscle problem. You possibly have a muscle problem. So then what do you do? For those of you who don't understand, you strain, you push hard, you're straining like you're nobody's business. And as you're straining, you're forcing more pelvic floor spasms and you get stuck in the vicious cycle there. And you know, it's really interesting. Some of you, like, holy hell, you can sit on that toilet and strain for an hour, not understanding the tremendous damage that's doing. That's not normal. Yeah, urinary hesitancy, that really points us to muscles. That was a big thing. This is in our summer 2018 IC Optimist. So if you're a member, just go to your member page and it should still be there even if you have the $25 membership. If not, email me and I'll send it to you. It's not a problem. All right. Well, how long have we been going? We've been going almost I was only going to do a 90-minute meeting. Now we've gone twice as far because I hurt my back yesterday. Plus I have a pimple right there. I'm vain. I don't want, I want a facelift. I'm not going to do it because I'm a redhead, but I wish I could go back 10 years. Okay. Anne says, can I take baking soda with HBP? I don't know what HBP is. Remember, baking soda is sodium. It could raise your heart rate. Raise your blood pressure. And so baking soda, you really should not be doing a lot of. Christy says, yes, half the people are not wearing masks anymore. They're idiots. They're idiots. I'm sorry, guys. The Delta variant is so much more infectious than the rate. This is exponentially worse than we were a year ago. The only advantage that we have is that for those of us who are vaccinated, it probably won't kill us, but we will carry it, and everybody should be masking up. And I'm telling you, I'm in a lot of medical groups. These doctors and nurses are breaking. They're breaking badly, and a lot are leaving, retiring. The strain that they're under is to go to work. And, there was one nurse who was working with a COVID patient who said, I spent 18 months protecting my family and I did it. We were successful. I slept in my garage or wherever. I took my clothes off. I washed everything. I was super, super careful working on a COVID ward. It took 3 days for the school to bring COVID into my house because her children went to school. 3 days later, they were all COVID positive. Zelda says about Dandy Blend. Yeah, Dandy Blend is a fabulous herbal coffee. Absolutely love it. This is a Dandy Blend Frappuccino. That's what I've been drinking. It's an herbal coffee. I blend it up with ice, coconut milk, and it makes it great. And it's actually kind of sweet. Then there's no sugar in it. So Dandy Blend is in our store. I think it's my favorite herbal coffee. Gwen says, you would like to show my doctor your SI joint is hurting me. Okay. Deborah says, my psychiatrist put me on Vistaril to help with my anxiety, but he said it may help the bladder. That's true. And yes, if you're having night terrors with Vistaril, that's a well-known side effect of hydroxyzine, also known as Vistaril. And that's why I stopped it. Dose matters. There are two different forms of hydroxyzine. Hydroxyzine HCl, also known as Atarax. It comes in a pill, and the lowest dose of that, I think, is 10 milligrams. The other one is hydroxyzine pamoate, also known as Vistaril. It comes in a capsule. Its lowest dose is 25 milligrams. Um, the capsule, the Vistaril is much easier on the body. It's kind of purer than the Atarax, the hydroxyzine HCl. The challenge is it comes in a higher dose. And so what they had me do is just open the capsule, and I just took half a capsule. So I was taking like 12 milligrams and anywhere between 12 and 14 milligrams when I was taking it. And I stopped it many times, never had side effects from it at all. Yeah, I mean, I'm telling you, I have never had night terrors before. It took 8 years to get there. I took it successfully off and on for about 8 years. Woo, but woo, that last year, those night terrors were awful. Like watching my family have their throat sliced in front of me. Awful. Like and it happened twice, and I knew immediately what it was, stopped it, never had it's never happened again. So we all have, weird side effects, and some people have paradoxical effects where you have the opposite reaction of what's intended. So you, for example, if you take a medication that's supposed to put you to sleep, it might make you super hyper instead. So some people have paradoxical reactions to the hydroxyzines too. All right, guys. Well, listen, we've been doing this for 3 hours or so. If you find these helpful, if you like these meetings, please come on over to our website and become a member so that you can get our magazine, because obviously this takes a lot of time, and so this is how we support what I do and what my very small staff. Four I've got 5 employees, most part-time, working from their home. But anyway, if you get our magazine, this is where we put our in-depth stories. The stories in our magazine don't usually come onto our website for at least 6 months, sometimes longer, because I want our members to get something new and different. And of course, we have our new book, IC 101. Took us 2 years to write it. I think you'll love it. And I already have plans for the second edition, which we'll probably do around December, with more information. So anyway, that said, let me give you your homework. For 15 minutes a day, I need you to do something to nourish your spirit and your soul. I don't care what it is. Go for a hike, go to church, listen to somebody, go find a little peace for 15 minutes a day. For 15 minutes a day, I need you to do something for your bladder or your pelvic floor. So make that getting on your back and doing your pelvic floor exercises, or preparing an IC friendly meal. Every day you have to make a commitment to helping your body. For 15 minutes a day, I need you to do something for your knowledge level. Like, seriously, one article a night. I was reading something, and it really chastised me, because it basically, what it said is, you are what you input. And I will tell you that because my job is challenging, working with patients all day is not easy. And one of the ways that I make my I ground myself is I read books, and I happen to like vampire books. Go figure. Or shifter books. Molly Harper. I love Molly Harper. She's a funny author. If anybody's looking for a kind of a fun Southern shifter book, or just Southern books. And last but not least, 15 minutes a day. Could you please laugh? Laughter will help your brain modulate pain. Pain that is accompanied by anxiety will be intensified by the brain, because your brain thinks your life is at stake. 15 minutes a day, that I'm sorry. And then pain that's accompanied by laughter, your brain will minimize the brain. So seriously, this is where you can get lost in TikTok, America's Home videos, watch some funny videos, talk with somebody on the friend. We got to get you laughing again. We got to get you laughing. There is hope. There is hope. There couldn't be a better time to be diagnosed with IC than there is now, because now it's not like 20, 30, 40 years ago where people were sent home and told that it was incurable. That's not the case anymore. Using our subtyping system, understand where we are doing a much better job of understanding what can cause your symptoms and how to treat those symptoms, and for many of you, how to cure those symptoms. Okay? So carry hope in your heart. All right, my friends. Hug, 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 hug. If you need me, you can call the IC Network. A phone number is right at the top of our page, icnetwork.org. I will see you later, alligators, in a while, crocodile. See you soon, baboon. See ya. All right. Goodbye, you.